Dr. Kamuri, our Associate Vice Chancellor, Research, Innovation and Enterprise, Professor Akison, representatives from various partner institutions, including the Ministry of Health and the Ministry of Education. Ladies and gentlemen, good morning. It gives me great pleasure to officiate the opening ceremony for this very important function in our calendar of events as a university and as Kenyatta National Hospital. Let me begin first and foremost by appreciating the good relationship the University of Nairobi and Kenyatta National Hospital has joined over the years and the work we do together. And I would want to encourage that. I would want to support that moving forward as the Dean Faculty of Health Sciences within the framework of the reforms which the university is undertaking and has already undertaken, as you all know. And so therefore also, even in the support we have received from Kenyatta, you all know, as you'll hear, this is our University Research Week. And part of this conference fits into that. That is the Joint UoN and the KNH International Conference on Health, this being the 5th of such an event. The organizing team, led by faculty from the Faculty of Health Sciences staff and the KNH, specifically Professor Sanjo and Dr. John Kinuthia and your team, I want to appreciate you also. Over the years, you have done a commendable job. So all of you, therefore, you are appreciated and most welcome for this very important conference for us. And so therefore, this opening ceremony will begin with Professor Atkinson and then the CEO, and conclude the opening ceremony with remarks from our Vice Chancellor. So with that, therefore, ladies and gentlemen, allow me to invite Professor Atkinson to make remarks. Professor Atkinson is our Associate Vice Chancellor in charge of Research, Innovation and Enterprise in the University of Nairobi. Professor Atkinson, please, welcome.
Thank you very much, Professor Machoki, for the warm welcome and the kind remarks. And good morning, everyone. Good morning once more. As you may be aware, the University of Nairobi is a world-class university committed to scholarly excellence. And currently, under the new reforms, we have got 2 divisions that actually manage the university affairs, the academic division, and also the research, innovation, and enterprise division. So as Professor Machoki has mentioned, I am the acting Associate Vice Chancellor in charge of Research, Innovation, and Enterprise, and also as the team leader or the chair of the University of Nairobi Research Week 2021, who worked very closely with Professor Osanjo on organizing this meeting. And therefore, it gives me great pleasure to warmly welcome every last one of you to the 5th International Conference on Health, jointly hosted, as Professor Machoki has mentioned, by the University of Nairobi and also the Kenyatta National Hospital, and we are very grateful for this partnership. So this year's conference, whose theme is Healthcare and Innovation in the Pandemic Era, provides an opportune forum for interaction, sharing of lessons, and also discussing our experiences in areas of critical interest in the healthcare, research and practices with delegates from all over the world. So our ICH 2021 is held at a time when research and innovations in healthcare has become a key agenda for universities, research centers, and also communities due to the COVID-19 pandemic that really visited us with very serious consequences. I'm certain that the conference participants will explore developments and also challenges that have come in tackling this very important matter of our time. Research and innovation being an integral component of the strategic vision of the University of Nairobi and partner institutions will conduct conferences in the coming month, also in the month of November. Because under the division, we have made the Research Week a permanent feature in our activities, in calendar of activities. And because of the challenges that we are facing currently, I think it's very opportune that many of the faculties are now looking at relevant thematic areas, and some of the conferences, I just mentioned a few, that starting from tomorrow, for the 28th and 29th of this month, we are going to have also the first international conference of the African Network of Constitutional Lawyers, and that also will be a virtual event. So in addition to the one that we are holding, the Ministry of Health and the one for lawyers, we also have the 4th annual Forensic Victimology and Victim Support Conferences that will run between the 22nd and 24th of November. We will also hold the 3rd Annual Development Finance Conference between the 22nd and the 23rd of November. We also have the 6th DBA Africa 2021 Management Review Conference, which is a one-day event on the 22nd of November. We will also have the 4th Annual Conference on the Status of African Women's Economic Empowerment. That will also run between the 23rd and 24th of November. The 12th African International Business Management Conference, famously termed AIBUMA, will be held between also the 23rd and 24th of November. Lastly, we are also looking forward to looking at the 4th Science Outputs for Addressing Grand Societal Challenges for Transformational Impact, and that will run between the 24th and 26th of November. So coming back to our 5th ICH conference, I would like to thank all the conference organizing committees. As I mentioned, we work very closely with Professor Osanjo and the team. The University of Nairobi, Kenyatta National Hospital. I want to also thank all the authors, those who are presenting papers, the participants, collaborators without whom we could not have held this conference. And so I want to thank every last one of you, and also thank Professor Machoki, who is the facilitator for this first session, and to wish every last one of you a very productive and inspiring conference of 2021. So congratulations again for being the first conference for the University of Nairobi 2021 Research Week. I'm very proud of you. And so thank you very much for everyone who has participated, who is participating, and hopefully we can see the outcome transforming our communities and our knowledge base. So thank you and God bless you.
Thank you, Professor Atkinson. This is your first year in office, and a lot will attest to the fact that based on your remarks, based on what you have shared with us, this is a research week, not like any other. You have listed such expansive international involvement and engagement, which we have not seen in the past very many years since the research week was started. As always, Kenyatta Hospital has always been part of us, Professor Atkinson. now that this is your first year as DVC research. And the CEO in particular, the CEO's office has been extremely very supportive of a lot of initiatives. In my view, I feel that the relationship between our two institutions is growing from strength to strength. And therefore, at this point, it's key and critical, therefore. We are equal partners in this. As you can see, it's a research week for the University of Nairobi, but Kenyatta Hospital has been extremely very pivotal in this. And DVC, let me just mention one person, the chair of the Department of Research at KNH, Dr. Kinuthia, who has also been extremely very pivotal in the research relationship between us and the KNH. In fact, his office provides some seed grants to our faculty, fully paid to conduct research. And that's a gesture I would really want to, the commitment I would want to mention, of course, fully supported by the CEO. I'm informed that Dr. Kamori is not in at the moment, but is very ably represented by Dr. Ondende, who is also a great supporter of many initiatives between KNH and the University of Nairobi, and indeed the rest, the line ministries. So Dr. Ondende, therefore, may I take this opportunity and great pleasure to invite you to make your remarks, please. Dr. Ondende.
Thank you very much, Professor Machoki, for those very kind words. I stand in for the CEO, Kenyatta National Hospital, who is out on an official engagement with the ministry at the coast. The Vice Chancellor, University of Nairobi, Professor Hutchinson, Professor Machoki, I referred to you earlier, Professor Sanjo, participating in the organizing of this event, the head of department, research and programs, Kenyatta National Hospital, all participants who have logged onto this platform of today, and all those who have gone into organizing this event, I salute you. It's my pleasure and great honor to welcome you to the 5th Kenyatta National Hospital, University of Nairobi International Conference on Health. And this conference, whose theme is healthcare and innovation in the pandemic era, couldn't have come at a better time. We pride ourselves as being part of the global efforts to make sure that healthcare delivery, research, knowledge dissemination are still ongoing, even with the challenges we have with the pandemic. And we know very well that world over, the virtual platform has overtaken what used to be physical meetings because of the challenges that have been brought to the fore by the coming of this pandemic. It's also exciting to note that this is the research week for University of Nairobi, our training institution. It is well known to all of us that KNH and University of Nairobi are joined by the hip, and these two institutions are inseparable. None can do without the other, and we support each other in making sure that the mandate bestowed upon these two institutions as premier institutions in this country is delivered. As a matter of fact, we guide policy regarding health, not only in training and research, but also implementing health policy in this country and guiding where it goes. It is therefore also exciting to see that in our theme, we have innovation standing out very prominently. And there is no better way of saying it, because in the face of this pandemic, we have no option but to remain very innovative in order to pacify the effects of this pandemic and also to help us live side by side with this pandemic if we have to see any progress in the delivery of our services. Otherwise, the pandemic, we know it keeps on evolving and changing in its way. And therefore, we have to keep on innovating to evade it, to pacify it, to make sure that our mandate is delivered at all times. KNH is focused on playing its leading role in support by providing tangible and credible research findings. That's why we have a vibrant department headed by Dr. Kinuthia, the research and programs. And that's why you see platforms like this are in existence to make sure that dissemination and sharing of our knowledge is possible. And as Professor Machoki has mentioned earlier on, we have deliberately set aside a fund that provides for research support and sponsorship. And this fund is easily available for both members of our societies, that is the University of Nairobi and KNH, to tap into and utilize. 100% available. So sponsorship would not be a question when it comes to facilitation from our side. I want to inform the participants that KNH is obliged to share all the information generated in this conference, and will put together the ideas that will be generated here into a report that can be circulated to policymakers and well as managers of the healthcare facilities and this country in general. And finally, I would like to convey our appreciation to every participant for undertaking research and for taking time to prepare papers for presentation. I want to thank all of you for taking your time to participate in this event, and be sure we are very happy and willing to continue with our collaborative effort at any time. At this juncture, therefore, I would like to allow the organizers of the event to continue on with this very exciting meeting, and with the lookout for the deliberations that are going to be made and the resolutions thereof ready for implementation. Thank you very much and feel very welcome.
Okay, thank you, Acting CEO, and your very encouraging remarks. That's a way to go. We are joined by the HIP, absolutely. And the best we can do, therefore, is to grow from strength to strength in terms of that which we must and can do together. DVC, even as I invite you to make the remarks on behalf of the Vice Chancellor, who is also out of town on very important official function, I also want to confirm to you the other area where we are working very closely with the Kenyatta National Hospital is in the area of the Ethics Review Committee. You know, research by its very nature will have no foundation, will have no basis without a vibrant, strengthened, and an international ethics review committee. And we've been working together for years in the popularly referred to as Kenyatta National Hospital, University of Nairobi Ethics Review Committee. It's one of the most celebrated international ethics review committee, the first one, and also working very closely with the KEMRI Ethics Review Committee. And out of these two, we have supported very many ethics to grow. We have mentored many, including some of the private institutions. So this partnership Professor Atkinson, is beyond just routine clinical care. We also support the conduct of research at that very high level. And so therefore, ladies and gentlemen, again, with that, let me invite once again Professor Atkinson to read to us the speech from our Vice Chancellor, Professor Kiama. Professor Atkinson, please.
Thank you very much, Professor Machoki, again, and thank you, Dr. Odede, for your remarks. So I will just go right ahead to read the remarks by the Vice Chancellor of the University of Nairobi, Professor Stephen Kiama, during the opening ceremony of the 2021 University of Nairobi and Kenyatta National Hospital International Conference on Health, today, the 27th of October, 2021. The Cabinet Administrative Secretary, the Minister of Health, Dr. Rashid Aman in absentia, the keynote speaker, Dr. Nolaskas Ganda, the CEO, Kenyatta National Hospital, Dr. Evanson Kamuri, ably represented by Dr. Odede, Director Research at Kenyatta National Hospital, Dr. Kinuthia, distinguished guests and participants, ladies and gentlemen. I am delighted to welcome you all to the 2021 International Conference on Health, hosted jointly by the University of Nairobi and the Kenyatta National Hospital. This is the 5th conference that we have jointly hosted with Kenyatta National Hospital over the last decade, and the first virtual conference our two closely linked institutions are jointly hosting. I have great confidence that the exchange of ideas and discussions that will take place during this conference, whose theme is healthcare and innovations in the pandemic era, will result in dissemination of knowledge and showcasing of innovations in research and healthcare. The COVID-19 pandemic has brought to the fore the extent to which health is both a driver and the outcome of development, and the prioritization of the healthcare agenda by nations globally is an opportunity to tackle key challenges in health, including infectious diseases, non-communicable diseases, reproductive health, and the universal health coverage. Ladies and gentlemen, over the years, the University of Nairobi has worked with the government of Kenya, local as well as international collaborators to resolve some of the daunting health challenges, including but not limited to: 1, researching innovative methods of countering the COVID-19 pandemic through collaborative research with local and international partners on the clinical trials of vaccines and also medicines, and the epidemiologic modeling of the spread of the pandemic. 2nd, building partnerships to advance research in HIV and AIDS, TB, malaria, and cancer, just to name a few. 3, applied and implementation science research in maternal, newborn, and child health through funded projects. 4, programs to build capacity to address mental health, among other areas, such as also the Ethics Review Committee that Professor Machoki mentioned. These research initiatives of the University of Nairobi and joint hosting of this conference with Kenyatta National Hospital underscores the university's commitment to achieving its vision of being a world-class university that is committed to scholarly excellence and one that is building partnerships and collaborations in a sustainable manner. Finally, I wish you pleasant and fruitful deliberations in this conference. I want to thank you so much for your kind attention, and may God bless you. Signed, Professor Stephen Kiama Ketahe, PhD, the Vice Chancellor, University of Nairobi. Over to you, Professor Machoki. So those are the sentiments from the Vice Chancellor.
Thank you, Professor Atkinson. And with that, you have officially opened the conference for us. And also given us the blessings to come.
Officially opened.
Okay, yes, thank you.
Yeah, thank you.
Right. Yes, thank you. I think with that, ladies and gentlemen, the opening ceremony comes to a close. And I want to thank all of you for your attention and appreciate all the presenters for this, so ably articulated, touching on key, the very important areas of our contribution to the government, to the national, regional, and international body of scientists, and that which we must do within the context of health. So with that, therefore, I also want to wish you all the best in these deliberations. We will be together. And therefore, allow me to hand over the rest of the program to Professor Osanjo and Dr. Kinuthia. Thank you very much, and God bless you all. Thank you.
So thank you very much for that warm beginning to our guests and also our leaders here at the university, Professor Machoki, Dr. Ndede, the acting CEO of Kenyatta Hospital, Professor Hutchinson, who is our AVC RIE. So thank you very much. I now call upon our first moderator of the day, Professor Julius Oyugi, to lead us through the program. Thank you very much. Welcome, Professor Oyugi.
Thank you very much, Professor Osanjo. I also want to thank the previous speakers, Professor James Machoki, Dean Faculty of Health Sciences, DVC Research, Innovation and Enterprise, Professor Hutchinson, and KNH CEO, Dr. Karimuri. I want to applaud them and thank them for the very informative speeches that they have given. Looking at the program, we have aligned two main speakers this morning. The first speaker would be a keynote speaker, Dr. Nolaskas Ganda, and the second speaker would be a lead speaker, Dr. Lois Acheng Ombajo. We'll then want to start with Dr. Nolaskas Ganda. I hope he's on board. Can we confirm that he's on board? Dr. Ganda? Is Dr. Ganda with us? Dr. Ganda, is he with us? Is Dr. Ombajo?
Sorry, Professor Yugi, I see you on board. Let me just hold on. Yes, Hada.
Dr. Ganda is around.
Okay, let's confirm that. Can you unmute him just to hear his voice before I introduce him to take over? Dr. Ganda?
Can you add?
Dr. Ganda? Can we confirm that Uganda is with us?
Yes, let's check on the ICT team so that we don't have any challenges. So just
Sure.
hold on. Yes, okay, just hold on.
Professor Yugi, these are different Dr. Ganda.
Pardon?
The one that is around is Joseph Ganda.
Or is Joseph Ganda?
Yes.
Okay. All right. So if Dr. Joseph Ganda is on board, Dr. Ganda, you are our keynote speaker this morning. And I believe your topic is on global response to COVID-19 pandemic. I'm sure everyone knows about COVID-19 pandemic. It's caused a bit of havoc in the whole world. And it will be interesting to hear from our keynote speaker a little bit about the response to this pandemic. Dr. Ganda, if you are on board, may I welcome you to make your keynote speech. Thank you, Dr. Ganda, and welcome. ICT, is Dr. Ganda connected?
Professor, I think Dr. Ganda dropped. We are trying to get in touch with him once more.
Ladies and gentlemen, as we are getting in touch with Dr. Joseph Ganda, because of time, I'm suggesting that if Dr. Lois Ombajo is ready and is connected to us, could she confirm so that we have her give her presentation before Dr. Ganda join us? Ladies and gentlemen, thank you for that short delay. I've seen Dr. Ombajo has just logged in. I think we can give her 1 minute to prepare and set up her presentation. But for those who do not know a little bit about Dr. Lois Ombajo, Dr. Lois Ombajo is a senior lecturer in the Department of Clinical Medicine here at the Faculty of Health Sciences. She's an infectious diseases expert, and she has been in the forefront in fighting COVID-19 since the pandemic started last year. She's participated in a number of documents that the government uses for treatment of COVID-19 patients, and I can see her slides are ready. On that note, therefore, ladies and gentlemen, may I invite Dr. Lois Acheng Ombajo to give us a presentation on COVID-19 treatment, what we have learned in the last 1 year. Welcome, Dr. Ombajo.
Many thanks, Professor Yugi. Ladies and gentlemen, good morning, and many thanks to the organizers for inviting me to give this talk today. As Professor Yugi has said, our talk will be on what we've learned in 1 year of treatment, and I'll just go ahead with the presentation. So these are my disclosures. I have none that are relevant to this talk, but we have funding for investigator-initiated clinical trials from ViiV Healthcare and Gilead Sciences, and I've also been a member of various speaker advisory boards. So to start us off is really just to look at the Kenyan situation and the global situation and why it is so important at this point in time to archive the lessons that we have learned. So currently in the country, we've seen a decline in the number of cases. Cumulatively, we've had about just over 250,000 cases and over 5,000 deaths during this period. We know that we may be plagued by the issue of underreporting just because of challenges of testing, challenges of confirming mortalities, and again, also deciding that these mortalities were really due to COVID-19. Over the last month or so, we've seen a decline in the number of cases, and the positivity rates from the tests that are done have just been below 2% for the last 2 or so weeks. But looking at a global picture, so this is borrowed from our World in Data, which does excellent visualization for various countries and various outbreaks globally. So Kenya is here. At this point, cases per million are just below 2.5. But what we're seeing in the recent past is that there are many countries that are beginning to see a slight surge in cases. So if we look at many European countries, if we look at the UK, even countries like Australia that have traditionally seen very low cases, are reporting slightly more cases. And I think what this says to us is that COVID is going to continue to be an existential threat. We really have to think about how we prevent further surges and how we, take note of the lessons that we have learned, so that as other cases come up, sorry, I think someone needs to mute. So that as cases come up, we're really ahead of the curve at every single time point. So some of the early lessons that we had when the cases first started to come up was one, learning to see how did our patients present. It's important that we know how people present so that we're able to diagnose them early. So this is reports prepared by the Emergency Operations Center, the Ministry of Health, and they keep a track of who is tested and how do they present at the time of testing. And over time, we have noted that the most common symptom in our patients has been cough. Then we have issues around fever, difficulty breathing, and the rest. When patients are in the healthcare facilities, again, our observation has been that cough was really the most predominant symptom, followed by difficulty in breathing, changes in taste and smell, and fever has become less important as a presenting or as a sign or symptom of COVID-19 while in the hospitals. This is work that we did at the beginning of the outbreak, and we're trying to risk stratify our patients. What were some of the risk factors that our patients were coming with? It was clear to us from the beginning that patients who were above the age of 60, and particularly males, were more likely to present with more severe disease. a large proportion of our patients had underlying comorbidities. And in this series in which we looked at close to 1,000 patients, about 43% had an underlying comorbidity. The most common at the time was cardiovascular disease, diabetes, HIV, and the rest in that order. Looking at how these underlying comorbidities are translated to outcomes and which ones actually related to poor outcomes, we found that just having an underlying comorbidity was more likely to be related to poor outcomes. And this is the number of patients with underlying comorbidity in this second column on the right panel, then looking at those who survived and those who did not survive, and the p-values for the same in the very last column. So cardiovascular disease was associated with a higher chance of non-survival. Diabetes was associated with a higher chance of non-survival, as well as chronic kidney disease and chronic airway diseases. So it means that even as we see our patient populations, they're already able to risk stratify and say which patients are most likely to do poorly. In terms of looking at our patient outcomes, what we have found is that outcomes are fairly good in patients who had mild to moderate disease. So these are largely patients who did not require hospitalization. And even if they did require hospitalization, they did not require any supplemental oxygen or breathing support. But appropriate risk stratification was important in identifying patients who could potentially have poor outcomes, hence the work that I was presenting earlier. We've struggled with poor outcomes in critical care. Part of this is driven by severity of disease, as well as challenges with personnel and critical care capacity in the country. I think at the outset of the pandemic, we quickly realized that we really had to organize how we provided clinical care. And what followed was really setting up of these COVID treatment units. Those did fairly well in managing the patients who had mild to moderate disease, but we struggled with patients who had more severe or had critical disease, just because the capacity to provide critical care in the country was fairly low. When we look at the evolution of pharmacologic treatment, so you may remember early last year, social media and every outlet was awash with images and suggestions of what could be done. From what's in the middle here, a lot of herbal therapies that showed up, and people are just walking around and picking some herbs and peddling those as potential cures. We saw from one of the African countries what was called COVID organics. And this, I was never more proud of my country, rather than the fact that we actually did not import large volumes of COVID organics because we did not have evidence to support that. Later on, we saw things like steaming booths and a lot of other therapies that may even have delayed presentation of patients in care or even facilitated transmission of COVID-19. At the outset, again, there was the thought that some of these repurposed drugs may have some antiviral activity. So initially we saw a large use of things like hydroxychloroquine, which were then shown not to be active. But in the initial stages, there's a lot of treatment with such drugs. One of the areas that we have struggled with is around antimicrobial stewardship. So there's been a lot of use of antibiotics such as azithromycin, levofloxacin, and other over-the-counter antibiotics. And one of the effects of this is that with time we may see a lot of emergence of antimicrobial resistance. And it's really about constantly reminding people that antibiotics have no role in managing a bacterial infection. The other area that we still struggle with is the emergence of this, a lot of false data around the potential role of ivermectin. And in spite of all our assurances to people that ivermectin has no role, we still see a lot of over-the-counter sales of ivermectin. So we've had to walk through and sort of manage all the conspiracy theories around some of these therapies over time. But what became clear to us as well is that for us to be able to manage COVID-19 appropriately, we needed to have a clear understanding of the pathophysiology of disease, just like we do with every other infection, so that even as we think about treatment, it truly is appropriate and is scientifically sound. So for COVID-19, some of the lessons we've learned is that early in the infection, even before onset of symptoms, is what we'd call a viral replication phase. Viral loads have been shown to be quite high, especially in the upper respiratory tract. And many times at this point, there may be no symptoms or only mild symptoms. This then progresses to a pulmonary phase where you may have a lot more virus in the lower respiratory tract. And this is a time that patients may begin to present with respiratory symptoms. So the cough and the difficulty breathing may begin to come at this stage. Then we go to an inflammatory phase, and this is what is really responsible for a lot of the symptoms and severity of illness that we see. And this is a point when we may begin to see acute respiratory distress syndrome and other organ failures. All of these phases being more prominent in those who are found to be obese and in those who have some of those comorbidities that we referred to earlier. So it means if we're thinking about treatment, in the very early phases of disease, we need to think about what will reduce the viral replication. But as time goes on, viral replication becomes less important, and we now need to think about what may counter this abnormal inflammatory response and what may counter some of the things that come with abnormal inflammatory responses, such as the increased coagulation, for example, and also about availing supportive care for those who may require respiratory and other organ support. In this next diagram, we sort of look at some of the therapies that have been used or tried over time and which ones have stood the test of time. So if we start from the top where we show an image of the virus, the initial phase is binding and entry, which means some of the therapies here would consider things like antibodies that may bind the spike protein and prevent them from binding to the ACE2 and other receptors. And then other drugs that may influence entry or inhibit entry. And this is where things like hydroxychloroquine were tried. But as I said, subsequent studies showed that hydroxychloroquine and chloroquine had no role. Then we go into looking at how the virus replicates and how it packages itself and is finally released. So if you think about, the whole replication process that may involve various proteases, for example, proteases that may cleave off the spike protein and other proteins as well. Here, some of the antiretrovirals that we've used in HIV treatment were initially tried. So things like lopinavir in combination with ritonavir went through large clinical trials early on, and these were shown not to have any impact either on disease progression or on mortality. Then looking at other stages in the replication. So we had drugs against RNA polymerase, some of which had been repurposed from other issues. So for example, remdesivir had initially been developed for potential management of Ebola, but it was found not to be useful in Ebola. There's been a lot of data for and against remdesivir, and I'll just share one of those a little later. So a lot of the data shown that it may have some role in reducing progression of disease, but not in reducing mortality. Ribavirin and favipiravir have not been shown to have any role in managing COVID-19. So then the virus will go through this packaging phase, and eventually you have assembly of the mature virion and viral release. And there was thought that maybe some of the agents, for example, that we use in influenza that influence viral release, such as oseltamivir, may have some role. But again, these have not been shown to have a role. So in terms of the antiviral drugs, there have been very few that have actually stood the test of time, and I'll just share two as we go on. When it comes to now looking at the other aspect of inflammation, as I said earlier, the excessive or abnormal inflammation is really responsible for the severity of disease and for the organ damage. And there's been a lot of focus on using various immune modulators to try and improve outcomes in patients. So one, looking at the Btk inhibitors, these are tyrosine kinase inhibitors, such as acalabrutinib, were tried towards the end of last year, and these were not shown to influence outcome. Then we realized that because of the impaired and abnormal inflammation, there's this cytokine storm where you have a lot of pro-inflammatory cytokines, and a lot of drugs have been tried to look at blocking some of these cytokines. So for example, the interleukin-6 inhibitors like tocilizumab have been tried and have been shown to reduce progression. And more recently, they thought that it may actually reduce mortality in patients who have rapid deterioration and have evidence of increased inflammation. There are the specific Janus kinase inhibitors, such as baricitinib, which has been shown my apologies, that has been shown to have some impact in patients, initially patients who had severe disease but not critically ill, and more recently some data around its use in critical illness. And then there are the various interferons again, which were tried about mid last year and were shown to have no impact on management. In terms of other immune modulation, corticosteroids have stood the test of time. We got the initial data from multiple large trials, such as the Recovery trial, that showed that indeed they did reduce mortality. Convalescent plasma was tried as well and did not show any impact on mortality. So taking the lessons that we've had from, understanding the pathophysiology, looking at various drug targets, looking at results from various clinical trials, looking at repurposed drugs, we've gone ahead to look at, one, what is not supported by current evidence, but also informing guidelines for care in the country. So here I've just listed a number of drugs that have been used a lot in the last more than 1 year, but really are not supported by evidence and should not be used. And this includes some of the things that I mentioned earlier: hydroxychloroquine, chloroquine, empiric antibiotic therapy, including use of azithromycin, ivermectin, convalescent serum, things like aspirin, vitamin C, D, and zinc that have gone through clinical trials and were not shown to improve outcomes of patients. So, in the recent past, we have launched the national COVID-19 guidelines. And I say this with pride because from the University of Nairobi and the Kenyatta National Hospital, we actually led the development of these guidelines. And some of the things that we focus on in these guidelines was, one, being able to appropriately assess disease severity in patients who are presenting to hospitals, because that helps us to stratify and prioritize where these patients are managed. So if a patient has mild to moderate illness, that's a patient who can be managed at home, taking into account the risk factors for severe outcomes that I talked about earlier. And patients who have severe illness have to be admitted, and those with critical illness will require critical care. We also look at all the evidence around various drugs, and that's sort of what is highlighted in this fairly busy slide, looking at what actually works. So assessment of severity, assessing risk factors, determining whether someone should be managed at home or in a facility, oxygen therapy, steroid use, and preventing coagulation that may come with a hyperinflammatory phase. So that's sort of what we've highlighted. And what we've tried to do as we develop these guidelines was come up with simple charts that could be put in facilities to facilitate patient care. There are some lingering questions that we still have. So as I said, patients who have mild to moderate disease can be managed at home. Some of them may continue to have severe illness. How do we improve outcomes in these non-hospitalized patients? How do we ensure that they don't end up admitted or even further get admitted and die? So that is still an area that is still not very clear. The other one is in this critical illness group, which is the last group in this chart to the right. This is a patient that have had significantly poor outcomes in the country, and we're still thinking about how do we actually improve outcomes in patients who require ventilation or who have multi-organ dysfunction. And I just looked at some evidence of what's emerging that we'll need to learn from even as we go on with treatment of COVID-19. So the first one is around improving outcomes in non-hospitalized and at-risk patients. So these are patients who have high risk for poor outcomes. This would be an elderly patient who has comorbidities. That's a patient who, even if they present with mild symptoms, they may progress on to poor outcomes. So one of the studies that was presented, I think just a couple of weeks ago, is what is called the Pine Tree study. And this is looking at this drug remdesivir, which I alluded to earlier. All the previous studies have looked at remdesivir in the hospital context, and none had looked at remdesivir in outpatients. So this was a randomized double-blind placebo-controlled trial where they looked at patients at risk, so either above the age of 60 or with these comorbidities, and they randomized to either receive remdesivir for 3 days or placebo for 3 days. And they followed these patients up to 28 days to look at either mortality, hospitalization, or whether they required other medical assistance during this period. And what they showed us was that the gray line looks at patients who are on placebo, and the blue line is patients who received remdesivir. And the y-axis represent patients who achieved the primary endpoint, which was either hospitalization or death. No patients died in this study, but what they showed is that remdesivir given very early in the outpatient setting actually reduced mortality by 87%. So as we go on, even improving our guidelines with time, we'll have to think about how do we incorporate some of this data into our current work. The other work is around use of monoclonal antibodies. And you may have heard over and over that monoclonal antibodies have already been approved in various countries for management of outpatients. So in this particular study, they looked at a combination of monoclonal antibodies, and most studies are using combinations in order to prevent any escape mutants, for example. So in this one, they had these two that were called BRII-196 and BRII-198, and they use this in patients who are not at home at risk and fairly early on in the onset of disease. And again, the gray line is placebo, and the blue line is, sorry, I think I've mixed up one of them. It went back, sorry. So again, randomized patients between placebo and the BRII-1 and the BRII-2. And looking at the outcomes, again, they looked at proportions of patients who are hospitalized or died. So here you see the placebo is the purple line, and you see a much larger percentage of patients who are either hospitalized or died, and estimated a 78% reduction in the risk of hospitalization or death. So these two studies give us hope that there's more that we can do for patients who are at high risk of disease progression, but are being managed at home. Of course, the questions in our context is that this require IV infusion. So we have to think of logistic issues of where would this be administered, who administers them, how are patients followed up, and the logistic arrangements have to be put in place if we are to approve and use this in country. More recently, and this was in the media a lot, was a new drug that can be given orally and may answer some of the challenges that we have with the previous two treatments. And this is called molnupiravir. And basically it just inserts the wrong triphosphate so that you have an error in viral replication. And it's gone through, again, randomized clinical trials. And basically what they found is that in high-risk patients, so for example, in participants above 60, the y-axis here representing the incidence of hospitalization or death, you can see in placebo, much higher risk of hospitalization and death, and the other three are varying doses of molnupiravir, showing a significant reduction in the risk of hospitalization or death. So again, this may give us an answer to one of those lingering questions of what do we do to reduce risk in those who are not hospitalized. The next question that remains is how to improve outcomes in critically ill. So what we've had so far is use of corticosteroids. And here is just a representation of one of the very early studies, I think from May or June of last year, the recovery trial. That was a large clinical trial looking at various therapies. But what they showed us was that using dexamethasone in patients who required oxygen or required mechanical ventilation reduced death by almost a third for those who required mechanical ventilation and almost a fifth for those who required just oxygen. So already in what we have been practicing is use of corticosteroids in all patients who require oxygen or who require ventilation. Occasionally, we have those patients in whom you've given steroids and you've done everything you can, but there's still something that you can do. And now this comes in new drugs, the Janus kinase inhibitors such as baricitinib. As I mentioned earlier, it's previously been tested in patients who had severe disease but did not require ventilation. And basically what it does is that it really reduces a number of cytokines. So it targets that inflammatory or hyperinflammatory phase. And there's one particular study that has now looked at patients who are mechanically ventilated. And basically they looked at critically ill adults, and they either gave them baricitinib or placebo in combination with standard of care. And this standard of care included steroids in majority of those patients. And here again, looking at the results, the y-axis representing percentage mortality and the x-axis days after randomization. And what they found that mortality was lower in the baricitinib group with an absolute risk reduction of 18.8%. And this is one of the best results we've seen from a lot of the clinical trials. So this is something that we'll be looking at, how do we incorporate some of this new data into our practice. So in terms of some of the lessons learned, even with pharmacologic treatment, one from the early phase where we saw all manner of therapies was that desperation led to wrong decisions. And that for us, it's important that we always defer to basic science. If something doesn't make scientific sense, it probably does not make sense. So we have to be willing to read, to learn from others. There are things that we still don't have clear answers to. What is sufficient evidence in the context of a severe pandemic? Is it one clinical trial? Is it two clinical trials? Is it an observational study or a randomized controlled trial? When is something sufficient for us to take it up in our clinical practice? And of course, we continue to struggle with the ethics of unproven therapies, which unfortunately always catch on much more than proven therapies. There's situations where we've done all that we can, and we always have to ask ourselves, when and how do we call it quits? How do we allocate resources where these are scarce? We've had incidences where ICUs were full and we were getting calls to try and find an ICU space for a patient, and there was none. How do you decide who takes that one bed that is left? So these are questions that we still continue to grapple with. They do not have easy answers, and I'm sure we'll still continue to struggle with them as we go along. I've had some personal lessons even as I come to the end. And one, I've had to learn, because this was new to all of us, to say that I do not know, I'm not sure, that I needed to review evidence, that I needed to consult, that this is what we know right now and this could change. And there are many instances when we said, for example, at the beginning, we said, don't give steroids to patients. A few months later, we said, oh, new evidence has now emerged that steroids will be useful. So it's been a constant learning process. And above all, that life is precious. We must enjoy every minute, and we have to take care of each other along the way. There are also national lessons that we've learned, and this was around setting up appropriate treatment facilities early, so that if something comes in, healthcare workers are prepared, we have capacity to manage. Oxygen has been a big challenge in the country. And right now there's a move, and there are a number of partners supporting equipping hospitals with large liquid oxygen cylinders and oxygen plants. And also the need to have good protocols and clear guidelines. As I showed you, we now have very good guidelines for management of COVID-19, but also the need to improve critical care capacity in this country. That it's not just about buying a ventilator, it's about thinking about who will take care of the patient in that ventilator. And also issues around cost of care. As I presented to you, there's so many new therapies that could potentially improve outcome of our patients. How do we introduce them into the country, and who bears the cost of this? So these are questions that I do not have answers to, and at some point, maybe I'll get to hear your thoughts about them. Thank you very much for your attention.
Thank you very much, Dr. Mbajo. A round of applause to Dr. Mbajo, wherever you are. Dr. Mbajo, I will have one question for you, and I'll also give the audience a chance to ask you two burning questions. My question is with regards to HIV. For most part of last year, there was this lingering question of having HIV infection. Is it a comorbidity or not? And a lot of publications came out, some saying yes, some saying no. In your work as someone who was managing COVID-19 patients, and based on what you know, what is your take as far as HIV is concerned? I saw you had some figures in your presentation. Thank you.
Thank you very much, Prof. So that's a question that, again, as you say, we've had a lot of back and forth, a lot of maybe it's a risk factor, maybe it's not a risk factor. In our initial work looking at our patient population, we did not find HIV to be a risk factor for poor outcomes. Having said that, a lot of other colleagues around the world have looked at the same issue. And what is emerging is that the well-controlled patient, patient who's on ARVs, with suppressed viral loads and good CD4 counts is not at excess risk. However, we have these patients who are severely immunosuppressed, who are not on treatment, who are newly diagnosed, who continue to experience a lot of adverse outcomes. So again, I think it's more for the patients who are not in control, who are not well controlled on antiretroviral therapy. Those ones have been observed to have poor outcomes.
Thank you very much. Do we have questions? You can post your questions on the chat. I will probably read them. Just 2 burning questions for Dr. Ambaju. So as I'm waiting for the 2 burning questions, Dr. Ambaju, just would you also talk about repurposing of drugs during pandemics, because it's something that is now becoming a common practice. It happened during the Ebola outbreak in West Africa, and we have seen it with COVID-19. What is your thought on that?
Thanks for the question. I think this is one of those where it's either hit or miss. So if we look at the experience we've had from COVID, a lot of the early repurposed drugs were misses. So what is the challenge with repurposing? One, sometimes many of the repurposed drugs may not be available. Where they're available, we may take a critical resource from other patients who require them. And I'll give an example of hydroxychloroquine, which quickly disappeared from the shelves. So these were drugs that are required by patients who had SLE and other inflammatory conditions. The other thing is often getting appropriate data very quickly is difficult, because getting large-scale clinical trials early on becomes very difficult. So it takes a while before you know whether a drug is useful or not. On the flip side, we've had some repurposed drugs that have gone on to show some utility. So if we look at things like let's say the Janus kinase inhibitors, things like baricitinib, that are now beginning to show some utility if we think about steroids, for example. So I think it's about, one, we have to think about the science and understanding pathophysiology, so that what we are proposing is actually plausible. You know, it's not a very far-fetched idea. Then 2, we have to think about supply chain issues. Is it something that's available, and does it take a critical resource from other patients who need it? And if it is indeed not available, how do you justify who accesses it at that time? So I think there's a lot of questions to be answered when we begin to think about repurposing. The issues of how to appropriately and quickly conduct clinical trials is something that we'll continue to struggle with over time. And what many large groups have done was to set up what they called adaptive clinical trials, where they started with something, and if someone immediately showed it wasn't working, it was dropped and they picked on the next thing. So ethics committees have to be very adaptive as well, so that we can quickly pick up what may be useful and drop what is shown not to be useful early. Thank you.
Thank you very much. I can't see any questions on the chat. I'm not sure whether it is my chat.
I'm seeing a question.
Please go ahead and read it. I can't see it from my side.
Okay. So someone said, have you done research to disprove the importance of vitamin C, D, and zinc? And the role of 3 in immune modulation is beyond doubt, supported by research. What is your take? So yes, there has been randomized clinical trials looking at vitamin C, high dose, normal dose, looking at vitamin D, and looking at zinc, and looking at whether they had any impact on progression of disease, whether they had any impact on self-reported symptoms by patients, and all the RCTs to date have not shown any impact of vitamin C, D, or zinc on COVID-19. So that one, I think the clinical trials are available for review. Someone asked, do we expect less cytokine storm in immunosuppressed patients during COVID-19 infection? So that's an interesting question. Some of the observations that people have seen is that there are certain malignancies, even patients who are on chemotherapy and all, who seem to get COVID, but not necessarily have very severe disease. But at the same time, there are certain malignancies, things like multiple myeloma, for example, in which patients had very severe disease. So I think this is an issue that I do not have a clear answer to. It's something that we'll have to continue learning over time.
Thank you, Lois. I think because of time, you may want to share with us the answers through the chat if you can. But from my side, I've seen there are many questions to be addressed, but I would want to take this opportunity once again to thank you for finding time and also to share with us, your insights on management of COVID-19, what we have learned. Thank you very much, Dr. Mbajo, and we wish to have you in future, scientific conference of similar nature to give us more information about this. Thank you very much. Ladies and gentlemen, our keynote speaker, I am told, is now on board. Dr. Nolaskas Ganda. Can we confirm that he's on board?
Yes, if you can hear me, I'm right here.
Wonderful. So thank you very much, Dr. Ganda. Dr. Ganda, according to our program, you are scheduled to be our keynote speaker. And once again, I wish to welcome you to this forum. Just before you make your presentation, Dr. I just want to give a little bit overview of your background, if you allow me. Dr. Ganda is an international health and epidemiology public health professional with a background in emerging and re-emerging infectious diseases, disaster response, and health policy. He started his career as a physician working for Ministry of Health in Kenya, then proceeded to work in the public health field, first as an emergency physician and health coordinator, and then as an epidemiologist at the World Health Organization. Dr. Ganda has more than over 10 years experience in emergency preparedness and response in Africa as an advisor on the development, implementation, and evaluation of the national and regional strategies and work plans pertaining to the prevention and control of high-threat diseases or pandemic and epidemic potential, response to infectious diseases and natural disasters, and at global level as a task force advisor on cholera control. Dr. Ganda is currently the acting head of the Health Emergency Response Program in the World Health Organization Kenya country office. So that's a little bit background of Dr. Ganda. Dr. Ganda, you are our keynote speaker this afternoon. May I welcome you to make your presentation. Welcome, Dr. Ganda.
Thank you very much, Oyubi, for the introduction. I hope you can hear me.
Yes, you can hear you.
Can you see my presentation?
Yes, you can see your presentation.
Yes, I'll try and rush through this. I was informed to give global and regional updates on COVID-19, and so I prepared a few slides which I think would be important. And I'll go straight ahead and give the presentation. Of course, there are many things that we cannot touch on. If I was to touch on everything, it would probably take the whole afternoon. But some key areas that I would wish to talk about in this conference, to brief the participants. First, of course, this is a standard slide, what we call the AP curve, showing what's happening in the world and in Africa. On the left is Africa, and on the right in Africa. So as you can see the waves in Africa, we are on the third wave, and it's just gone down. The same thing is happening globally. In the number of cases in Africa, you can see more than 6 million, globally more than 240 million. And the deaths also in Africa and globally. So it has been, the pandemic has really had an impact on the world, and we'll talk about this. I'll show you a few slides talking about this. Now, I'll go on talk about again Africa. Where are cases coming from? Look at it from an Africa perspective. You can see the countries that are of concern. A disclaimer on this slide is that we have a problem of testing in Africa, and so as much as we are showing where cases are being picked, we know that we are not able to test well. South Africa has a very good system, and that's why they're able to pick and to reported we are significantly a reporter of cases in Africa. What about, sorry, just a minute. Deaths, what about deaths? As you can see, the number of deaths being reported, Kenya, of course, again, being top 5, but again, our system not picking well. So these are the countries that are of concern if you talk about it from a WHO perspective. Kenya from East Africa, Tanzania, we know what happened in Tanzania, we're not reporting, but now the backlog is coming. Since they have gone back and looking at their records, and you can see that there was a lot going on in Tanzania. The other countries have problems. And the DRC has a bigger problem than COVID. And probably that's why in the remoteness, they're not reporting. But looking at what is the trend that is going on in Eastern Central Africa, you would probably think, or you not be wrong to think or to say that whatever is going on in DRC is almost equal to Kenya or Tanzania. Now, what are the factors that are leading to this transmission? Why has the pandemic continued? We all know about variants. Some of you have heard about the variants, the beta, what we used to call India, Brazil, UK, South Africa variants. So the virus keeps evolving. They keep recording new variants through a process of sequencing. Population in Africa, very few have been vaccinated. I'll show you the numbers, looking very good. And so there's a high susceptible population. And so the virus is able to spread and to sustain the spread because of this weakness. Social mobility opening up. You have seen what's happening in the world, including here in Kenya. We cannot live as a closed community. We have to open up our economies. We have to balance the issue of surviving with the virus or surviving or living side by side with the virus. And so there are schools of thought that if we are to close up the economy, the impact of closing up the economy might even be worse than the virus. So this is the third reason. And the last one is misinformation, disinformation, what we call infodemics. And this one you might have heard on many people in many forums where you may see people not wanting the vaccine, people being scared of the vaccine, people thinking the vaccine has other properties that are not harmful to them. Many stories. So this leading to vaccine hesitancy. Others, like if you visit countries like the US, others really don't believe that this vaccine and this virus is that dangerous, and so others they will not want to take any measures like masking. So these are the issues that are coming up, and we may continue to see the pandemic move on to a third year, if not fourth. Testing and the strategies. What are the issues? Not new to most of us who work in programs, including programs in the universities and institutions. The issues of funding in Africa, issues of supply chain, a big problem we've had in Kenya. Regulatory review and approvals. Some of these things take a lot of time to get sorted out. Restrictive ability case definitions, every country taking its own stand. This is there's something called a pandemic treaty that is being discussed at global level now to take care of these issues. Governance issues, you've seen in what happened in Tanzania, Burundi, testing issues. We talk about this in political will. So with all, these are the complex issues that we have to deal with when it comes to COVID, really touching on most of the society, different areas with society. I want to move on to variants. I'll talk about the variants we may have heard about the alpha, the beta, the gamma, delta, and many others that we continue to register. As you can see here, what is happening in the world, the variant that is now of concern has moved on most of the continents. The Delta variant, the very dominant in almost all the continents. But before that, we had the alpha fast that was predominantly in the Americas, in the Western Pacific and the Eastern Military, and then the Delta took over. Delta is the one that came from India. We'll talk about this again, a bit infectious. This graph shows you infectivity of different and transmissibility of these different variants that I've talked about. We'll not go into the detail, but just to appreciate that they are not the same, they're different. We can see from the Delta to the right to Zeta on the left. They're not the same, and this is what we've talked about. The virus keeps changing, and with this change, it becomes a problem for us in responding and controlling. As to why they change, this is something that has studies, and we have very many scientists here who know how viruses operate when it comes to genetic shifts and drifts. And this is not something new to us. We know that it happens not only in COVID, but other viruses, the influenza viruses, the H1N1s, and other ones, which we study. And so like coronavirus, this one, same thing has happened. This one now showing you, at least when it comes to Delta variant, why it was such a concern for the world. And you can see what happened in India a few months ago. The Delta variant was registered. Very highly infectious and more deadly than the ancestral strain. You can see the ancestral strain there in the color purple and the Delta in blue. The big triangle showing you and rectangle showing you just the range of the infectivity and transmissibility. Ebola on the left side up there and the measles on the right. So you can appreciate the Delta being different from the ancestral strain, and that's another problem that we've had. Ebola was a very big problem in Eastern Central Africa, especially the West African outbreak. Very high case fatality, very scary disease. But we can see that the Delta variant is much more transmissible than the Ebola. This slide is a bit much. Initially, I did not want to go deeply into it, but it's beginning to see and to realize different schools of thought and different studies showing us that vaccination only will not stop the disease. Will not stop the pandemic. We need to continue social measures. Some studies are already coming up and showing that we need something like masking is very important. Even if the vaccine is effective, without social public health measures to control transmission, we may not be able to achieve what we want to do, that is to control the pandemic. And so it's important that we take note and we continue even in our institutions to make sure that measures are in place, and not only in place, people adhere to these measures. You have to mask because it actually matters, even if you're vaccinated. It happened in the UK where when they reached a high vaccination coverage, they moved to open up the country, even not allowing masking. But I think they are rethinking, the public health England is rethinking this. What is WHO saying about these measures that we are taking? Again, I've talked about the economy. On the left, it's a very loaded slide because there are many. It's just showing you the impact of some of these measures we've done, and what can we do to continue to live? Because we cannot, for example, have a curfew forever. We cannot restrict movements forever. We cannot close borders forever. What can we do? The best and what we're moving towards is something called risk-based approach. Picking a risk that is highly common in your place and insisting on it, like masking as a measure to control and transmission through the air. It works, and you can pick this and really be to adhere to it. So it's a risk-based approach. And if you look at other measures that you put in place, you can relax other measures like quarantine, like restrictions, like what Kenya has done, curfew, because you need to open up the economy for other parts of the economy to work. So a risk-based approach, not only in the country, but an institution can take a risk-based approach. Schools can take risk-based approaches to controlling the spread as we continue to institute other measures like vaccination for children is no longer there, but it's moving there towards that. So it's important to see that we can adjust and try and live with the virus. These are the areas for a human being to survive. I mean, the life of a human being comes in stages. Of course, you can see from there as a child. You would not miss to be affected directly or indirectly by what I'm displaying here. From when you're a child, you get sick, nutrition issues, you'll probably get malaria, or your friend will get malaria, or a cousin or a relative will get any of these diseases. So this is part of the disruptions we are seeing when it comes to sexual health. And COVID is in all these areas. You have to appreciate that if you were to dig deep, and which you have done, I'm not going to do the presentation here now, but the analysis has been done that true, if you look at the number of people who have been enrolled in HIV clinics has gone down. If you look at the number of testing done for HIV last year between 2020 and this year, it has gone significantly down. When it came to maternal health, the ANC programs was not really affected. Mothers still were able to access these clinics, but when it comes to child health, they were affected. So disruptions did happen, and it's important to take note. And of course, when it comes to mental health, we have seen, even on TV these days, it is shown there's a lot of issues when it comes to mental health. These are part of the disruptions we're seeing when it comes to that as COVID has brought. Science is already picking this up, and true, as you can see, not only in Kenya, there's a global mental health problem related to COVID, and many papers are beginning to show this as a problem. I'll just pause 1 minute as I adjust something in my screen here. I cannot see half of my slide. I do not know why. All right. I'll move on to vaccines and boosters. I've mentioned to you that we have had a problem of vaccines in Africa. This slide just appreciating to you that as much as we've had a problem, there has been some movement. It's not so much, but we have received almost 250 million doses in Africa. Other countries have vaccinated more than 25 million, others have vaccinated less than 1 million. For Kenya, the numbers I'll show you. And it's good to appreciate the countries. The countries in Southern Africa and Northern Africa have been much better than East and Central Africa. It's just what we're showing here. And also there's a problem with usage. Again, I'll show you that others are disposing of. We're having vaccines that are being disposed because they've run out of data. They've not been used in time. They have expired. So it is, when it comes to procurement, you can get the vaccine. You have to make sure you administer the vaccine, and the usage must be in time. I'll show you the data around this. This just shows you in the beginning what was happening in Africa from in March when we started receiving the vaccine. The uptake was poor, but it has improved from August this year. In Kenya, you have noticed that not only are the target population coming for vaccines, even the others. You have other schools, many between the age of 30s and 20s and 30s and up to 40s have received the vaccines, including in the institution. So there's been a pickup of vaccine use, but not very good. If you look at this graph, it just shows you the countries, how countries are doing. Only about eight countries have used more than 80% of the vaccines they have received. Kenya is around 62%, not very good. It keeps going fluctuating up and down, but you can see that some countries are doing as better than others. You should appreciate having vaccine is not being given a vaccine is also it needs a lot of pressure for you to make sure it is used and rightly used. So by comparison, if you're keenly looking, I think Kenya there is around 60%. And again, the target set by the regional office for us, some of them are achieving, some of not achieving. 10% of the population. Kenya is now at 5.3%. And I think if you look at only Seychelles, Mauritius, and Morocco, for Seychelles, Mauritius, it's a very small country. Morocco is a big country, but they've managed to vaccinate quite a chunk of their population. So there are different targets being set. Others are meeting the target. Kenya is not appearing in this list so far. This was about a month or so ago. I think we were that time at 3%, but now we are around 5%. and they keep adjusting the target population. But the target population for Kenya now, I'll show you, is 10 million by December. Again, appreciating what's happening in Africa, Central Africa being where most of the problem is when it comes to vaccines. The details, I'll share the presentation for you for those who would want to go into detailing and analyzing what is going on when it comes to vaccines. This is about Kenya. As you can see, I've told you, look at on the left, target by December is 10 million. There was another target by 21st October to reach 5.8 million. We didn't. We reached 4.9, around 5 million. And the president is an address, really mentioned this, that we have reached 5 million people. And our target was 5.8 as the health sector. So far, it's not been reached. I think it's 4.9. And the number of adults vaccinated is 5.3. And I'm sure most of you know all the vaccines that we have received. It's always in the media, including the Russian vaccine, Sputnik, which is rarely talked about. So if you look at on the left side, that the graph shows you our usage is not so bad, but we can do better. Yellow, steeper than the blue. We can catch up. We need to vaccinate more people as we open up our country. The targeted populations are on the right: healthcare workers, security officials, teachers, and those above 58. Very low. 13% is very, very low. It's a worry to us. The 13% amongst that above 58-year-old, they should get vaccinated fully. 26% for first dose is still also very low. 13% second dose is not. It's alarming. We should push to have this target population vaccinated. Okay, healthcare workers have done pretty well. As you can see there, in the security officers and the teachers still need to work on that. They're almost reaching halfway. There's ongoing discussion, and maybe this has been, I don't know if this was discussed before, on mixing and matching of vaccines. Global discussion on this. Many studies are coming out. For example, one study I've seen is that mixing Pfizer to get a first dose of rather AstraZeneca and a second dose of Pfizer, the efficacy goes very high. Another discussion is that because of lack of equity, people are talking of halving the dose of the booster dose. So, for example, if the initial dose of any that you are given is, say, 2 mils, the booster should be given as 1 mil, so that there's more vaccine for more people. So this is just appreciating, so all of you can appreciate that there's already a global discussion, and I'm sure you have seen that other countries and other people have received the booster doses already, like US. They have already, Joe Biden has already received this booster dose. Israel, they're already giving booster doses. I will not go through this. This is just an explanation of what a primary and a booster dose is. It's just put there for when you share the slide so that the many can at least appreciate the meanings of what we mean by that. And so when it comes to booster dose, again, you can dig deeper. I will not analyze this slide, but you can, when you get it, there are many indicators that I've looked into when studying why and when introduce a booster dose. And so there's a vaccine efficacy, the severity of disease, the symptomatic disease, which Lois has mentioned. The studies are before you introduce. For example, you can study AstraZeneca versus Johnson & Johnson. You can study Sputnik versus Janssen. And there are many studies ongoing as to whether which combination is good and which combination should be recommended. So this is just appreciating those type of studies. And that's why the global discussion is ongoing. And hopefully by January, we will have maybe a stronger paper on this. But for now, I'll show you some thinking around this. That if you introduce, for example, you know that the vaccines wane, the efficacy wanes over time. So before we really fully understand how the vaccines will be introduced, we should not rush to introduce a booster dose. So these are just some thinking around this. What about the side effects? We know that, for example, Moderna has a side effect on the heart. and causes GBS by Janssen. We can, if we quickly introduce a booster dose, and yet we've not understood the initial primary dose, won't be creating more problems. What about vaccine equity? We have shown you a slide where most of Africa generally don't have vaccines, and yet Europe and Asia have vaccinated more than 70% of the population. Isn't that wrong as humane, for humanity to proceed this way? So as much as science is there are also these are schools of thought that you have to put into consideration. And so the issue of equity, and that's where the DG, Director General, Dr. Tedros mentioned that let us look into the issue of equity before continuing to have booster doses. Equity must come first. So an interim statement was given by WHO. I'll summarize it. I will not go into the details. The summary is that equity first, before we move into boosters. But again, countries are independent. Others have started having booster doses. Others are even public about it, like the US. And so this is an ongoing global discussion. So it's something that you have to appreciate. I'll leave this the statement here, but I've talked about it. I've already mentioned this when I was talking about the booster doses. There's a statement that was issued by WHO. This is what most countries that have not accessed vaccines are relying on, and WHO will continue to push this agenda so that we have more countries that have not received enough doses to have access to this. Moving on. Already, this was published by the FDA yesterday, the Food and Drug Administration of the US. They have proceeded and they want to vaccinate children between 5 and 11 years. So countries have moved on, and these administrations are already issuing guidelines on this. And just for you to appreciate that we are not in the same page with other countries. And they are ahead, and according to their studies and the institutions, they believe that booster doses, for example, for this Pfizer should be given to people between 5 and 11-year-olds. We'll see how this pans out. COVID is still new to us, and we'll learn more as we move on. On the left is a table showing you the scenarios that they used to make their decision. It's a bit detailed, maybe for epidemiologists and all for scientists who would want to study that, but it's online. A few challenges. I've talked about the vaccine equity. You can see what is going on in the world, where we are as a country. I've talked about testing. This is the regional director for WHO. Our study was done. Those are the countries that were targeted: Burundi, Cote d'Ivoire, DRC, Congo, Guinea, Mozambique, Senegal, Zambia, Republic of Congo. In Africa, only 14.2% of infections are being detected. So all the numbers I've been showing you, by this study, we believe around 14% is what we're detecting. Most go undetected or just walking. We are flying blind. That's what the regional director says. But we need to know what is happening in our communities for us to make decisions. And so for Kenya, I can tell you that Kenya is proceeding to invest in having a large-scale seroprevalence survey done by KEMRI. To understand what is really going on in the country. They will go into the communities and collect blood from a large chunk of the population, and we will wait for these results. But just to mention that some studies have already come out. KEMRI, Wellcome Trust have done studies, and other institutions have done studies. I'm sure even Nairobi University has done a study when it comes to seroprevalence. Maybe I think one was on mothers attending ANC. Another one was on blood, people donating blood, and they had varying detection. Others had 50% had been exposed to COVID, others as low as 17, others 37%. But you can appreciate from 70 to 50% from these studies with very small number of sample size, you can maybe get to know an average of where Kenya is. But from this study, very low. It's a problem. Testing is a problem. Variants of concern. I've talked about the variants. You can see that for us sequencing, it's something called sequencing where we test and can understand that these variants and adjust our public health measures. our labs are not doing very well. But not for us, for Kenya, as you can see where we are, but for the world, you can see where the West is. For us, we need really to improve on sequencing. Sequencing is a very expensive exercise, but it's an investment that we need to do because viruses are going to be with us. They have always been with us since the days of the Spanish flu, to H1N1s, to coronavirus, to Ebola virus. These viruses are there. They're part of this ecosystem. So as humanity, we need to invest in some of the systems that we have developed. We understand what's going on around us and not fly blind. When it comes to variants, again, this is what's happening in the UK. If you look at the bottom to your right, there's a blue curve coming up. There's a new variant that has already been established in the UK. They're calling it the Delta Plus. They have not really understood how it's working, but they believe it may be more infectious than the Delta, which is already very infectious, more infectious than the original strain. And so you need to just have to appreciate that you need to continuously do what we call sequencing in the laboratory to understand how these variants are changing. This is quite new, started in July, and it's already significant. We can see on the blue right side, it's quite significant. We'll see how when it comes to epidemiology, virology, immunology, when it comes many. Hello, can you hear me?
Dr. Ganda, we lost you a little bit. I don't know whether
okay.
Others were hearing.
Okay, I think I was down here. Yes, I am back. So I was right here. Yes, bringing institutions and people together at all levels to try and realign ourselves and see what we can do to improve our situation post-COVID. And this strategies, many strategies are being put, and it will be a global discussion on how to proceed. Again, when it comes to universal health, there's a position paper that has already been published. This was released last week by the WHO to revisit the issue of universal health coverage and the health security, looking at what we have faced since last year. No one knew this was going to happen to us. And so we need to look and make sure this does not happen to us, but then invest again in the healthcare system so that we will be able to respond to future. For now, our worst enemy is complacency. We have opened up the country. WHO has recognized this. Not only Kenya, but many countries have opened up. We are wearing masks. We are keeping distance. We have opened up the corner. I've seen this. We are keeping clean. We are avoiding crowds, as you can see what we are doing now, and we are getting vaccinated. But we should not be complacent. We should continue to the end. Thank you very much.
Thank you, Dr. Ganda. Ladies and gentlemen, a round of applause to Dr. Ganda. So that was very educative, Dr. Ganda, on your presentation on global and regional updates on COVID-19. At this juncture, I want to open it up for a few questions from the audience, but I have one question for you before I will go to the audience. The audience, you can share your questions on the chat so that we will probably read them later. My first question is, when COVID-19 came around last year, one of the key factors which was thought was going to drive, transmission and poor outcomes in terms of those who are going to die from COVID-19 was poor health infrastructure. And Africa, as we know, most countries in Africa have very poor health infrastructure. But looking at the number of deaths that you're projecting on your slide, comparing Africa with other countries, it looks like we didn't bear the heaviest burden of COVID-19 in terms of deaths compared to other countries. What do you think, could have happened in Africa that we've not seen, major deaths due to COVID-19 as compared to other countries in Europe and America?
Thank you. May I proceed?
Yes, please.
Yes, this has actually come up very many times. The issue of what happened to Africa. How comes with our poor health systems, with all these problems that we have, we didn't bear as much, we didn't see as many deaths like the West. My comment on this would be, first, scientifically we can have a discussion on this, but from a science point of view, it would not seem so. What we have launched and what we are seeing within the Ministry of Health, and we have talked about it, the health sector, we are doing something called rapid mortality surveillance. What we're already seeing is that the mortality that was recorded last year and this year was not actually the same as we're reporting in our numbers when it comes to these slides. And these are issues to do with our systems. Again, not being able to pick as many people who died because of issues that we faced, we faced with our systems. That would be the comment from my end. It's not really true that we're not as impacted. We didn't have as many deaths as outside there. We just don't know how far this COVID went when it comes to deaths, when it comes to Africa. You can see a country like DRC, which is largely remote, barely have any systems. You saw what happened in Tanzania. In the beginning, there was no COVID, but you can see the numbers have come up. Some numbers are looking as more than Kenya with a better system. We're already seeing that the deaths there were actually worse. So we really need to look at this again. There are already initiatives to look at what happened when it comes to deaths. This initiative is between the Ministry of Health and the Ministry of Interior. And with time, we'll be able to determine and say, look, it may not have been very bad, but it was not as good. Thank you.
Thank you very much. So I'll read two questions which are on the chat, Dr. Ganda. The first question is from Isaiah Kaunyangi, and is asking, what is the state of preparedness in terms of disease surveillance in Kenya? Maybe I can read two questions and then you can answer them, together. The second question is from Ezekiel Mecha, is asking, from your personal view, what is your advice on vaccine mixing? Immunologically, we have primary and secondary response upon vaccination. Do you think this may not be adhered to during vaccine mixing? Thank you. So those are the two questions that maybe you can address. Because of time,
yes.
The rest
yes.
you can probably share the answers on the chat. Thank you.
Yes, I'll share the rest of the answers because I also have. Yes, you can hear me. Hello, can you hear me?
Yes, please. Go ahead.
Yes, so yeah, I'll respond to these questions.
I'll
respond to this too, and the rest I'll respond to the chat. The state of our surveillance, not as good as the West, but compared to the other countries in Africa, the Kenyan surveillance system is actually quite good. It gives us not 100%, but I would out of 10, I would give it as 6.5, which is quite good for Africa. There's a lot of efforts to improve the system. COVID has even shown us more weaknesses that needs to be improved. So the surveillance system is not as bad. It should be commend actually the Ministry of Health for taking this system this far. There's a new strategy on surveillance being launched. It's actually being finalized this year, WHO with the Ministry of Health, and it's going to be rolled out next year. This is going to even expand on the surveillance system to make it even better, to cover areas that we cannot cover. For example, when it comes to suicide, we want to monitor how how many people are committing suicide and why. So the surveillance system wanted to pick even more. Now, the second question on mixing and matching, my personal position, I'm a scientist. I would not give a personal opinion, but I would rely on science on that. But the way science so far has taken us, it shows it's promising, because we know that these vaccines have different efficacies, they have different strengths and weaknesses. So mixing and matching may be good, but we shall follow science, and I don't think a personal opinion would be the best at this point in time. It's too early. And also when it comes to our system, we may have, there's a committee looking at this. If our system will be able to perfectly have this implemented, these are the areas that we can leave it to the committee within the Ministry of Health to answer. But so far, it's good to follow science. Science has taken us this far, and there are strengths. When mixing and matching, it's really to strengthen, and not to weaken. Thank you very much.
Thank you very much, Dr. Ganda, for addressing those questions. I believe the audience and myself have learned a lot from your presentation on the matters COVID-19. You have really touched on, areas which are important to us as far as COVID-19 is concerned. For example, you have really given us a lot of information about factors driving transmission of COVID, how testing of COVID impacted, the numbers we are getting in terms of our countries in Africa. You've also told us a lot about vaccination, from the types of vaccines, mixing of vaccines, and issues to do with vaccine equity. But you have also given us an overview of COVID-19 variants, including the one that is currently being identified in UK. Dr. Ganda, thank you very much for your keynote presentation. On my behalf and on behalf of the organizers of this conference, I want to thank you and thank you again. And we hope that you will invite you in future when you have this kind of scientific conferences. Thank you very much, Dr. Ganda.
Thank you.
So back to the audience. My session for moderation is coming to an end. I want to hand over this to Dr. Kihara. Dr. Kihara, are you with us? Dr. Kihara?
Yes, I am.
Yes, so Dr. Kihara, please take over to share with us how our participants are going to share their posters. It's now the poster session. We are done with the presentation for this morning. Thank you very much. And back to you, Dr. Kihara. Asanteni sana.
Thank you very much, Professor Oyugi. Participants, I have sent a link to the posters. And we have Mr. Agustin who take us through the process, how you're going to access the posters. So the host can enable Mr. Agustin to share. Yes, thank you. Mr. Agustin, you're in. You're welcome to share. I have sent the link to the chat. Mr. Mutua, can you hear?
Yes, I can hear you. Just a minute.
Okay, fine. So he will share with us the page where the posters are located. And once you're there, the page is easy to navigate. You'll be able to click on the poster gallery, then to give you a list of poster 1 and poster 2. There are several posters in each, in poster 1 and poster 2 group. Then you can click on them. And there's also provision where you're able to ask a question. So those who have sent posters, kindly be on standby. Keep on checking that link in case you have any question, then you can answer the attendees. And in case you ask a question, to ask you for a username so you can put your name. Thank you. Mr. Mutua, are you able to share?
I hope now my screen is visible.
Yes, it is.
Good afternoon, all. So I have sent the link in the chat box. So when you click on the link, it opens a page that looks like this. You can see it's the 5th International Conference on Health. The theme is Healthcare and Innovation in the Pandemic Era. So when you can scroll down, or you can click on the poster gallery on the navigation bar. It takes you down here. There are some posters. There are about 11 posters. So when some are in the first page, others are in the second page. So you can maybe just click on probably the first page. It opens. You give it some time, the posters, as they load on your screen. My internet is a bit slow, so they're taking a bit of time, but as you can see, there's some posters over here. If you'd like to scroll, there's some buttons at the end, both on the right side and on the left. You can click on them to just scroll to the next. Or if you just leave the page as is, they will scroll automatically after some time. If you are interested maybe in a specific poster, you can click on it. You can see, like on this one, you can click on it. So it pops up on my screen. Now I can be able to read what the poster is about: factors affecting implementation of quality management systems in ISO 15189-2012 accredited labs, a survey of staff opinions at Kitale Regional Public Health Lab by Brian. So I can also, you can see when I've opened the poster, there is this magnifying sort of lens. I can still click on the poster to zoom in. It will take some time, but now, depending on your screen size, you can be able to zoom in. Down here, you can see the other posters on the same page. You can scroll. You can, on the top here, there are some buttons. This one is for play. It will take you to the next.
What makes the number?
The slideshow, it creates a slideshow. You can also ask a question. You can see the posters at the top here, they have an ask a question button. You can click on it. Then once you click on it, you can see the posters on my left side of the screen. And there's an area here where ask a question for the poster. Now you can type your question here. Before it posts, it will prompt you to give your name. So when you give your name, it will appear here. Dr. So-and-so, somebody has asked about this. So whoever visits this page after you will be able to see what you have asked. And also whoever is presenting the poster can be able to answer it, and you can visit it later and see what they have answered. I hope that is clear enough.
Thank you. Is that all, Mr. Mutua?
Yes, I think that is all. If there are any questions, I'm available to answer them right now.
We can take one question, and I can mute the people in your background. Thank you. Okay, participants, Let's access the link. In case there are any issues, kindly let us know. And with that, we are going to end this session of the conference. The next session is starting at 2 p.m. exactly. Kindly log in punctually. And thank you for attending. Enjoy your lunch. God bless.
It's a great thing that KNH is becoming a fully referral hospital because we'll focus more on what we were intended to do right from the beginning. We deal a lot with the subspecialty cases. For example, in my field, I'll be focusing more on the vitreous and the retinal conditions in the eye. And I believe that will make me a better person and will make me better offer services to the clients who will be coming. In ophthalmology, we have 5 different subspecialties. We have anterior segment, which deals with the cornea. We have glaucoma, which deals with eye pressure conditions in the eye. We have pediatric ophthalmology, which deals with pediatric cases pertaining to the eye. We have oculoplasty, plastic surgery around the eye and the tumors around the eye. Then we have...
We're excited to have you here with us. And I hope you really enjoyed the morning session. My name is Dr. Rhoda Kalundu. I work at Kenyatta National Hospital Healthcare Quality Division, and I will be moderating the first session of the afternoon session, and we hope to have a good time together. So allow me to introduce our guest speaker, Dr. Willis Aquale. Dr. Willis Aquale is a medical doctor and malaria specialist with extensive experience in public health management. Currently, Dr. Aquale is the senior advisor for the American Leaders Malaria Alliance, supporting His Excellency President Uhuru Kenyatta's work as the chair of the ALMA. He is also the chairman of the National COVID-19 Vaccines Task Force in Kenya, and he holds a degree in medicine and a doctorate in tropical medicine, specializing in malaria epidemiology and control. And I would like to welcome Dr. Aquale to take us through this session, where is the lead speaker, and will be telling us about COVID-19 pandemic response in Kenya. Dr. Aquale, good afternoon.
Good afternoon to you. Good afternoon, Chair, and good afternoon, everyone. Let me first start by thanking everyone for the invitation. It's been a busy morning, but I've just settled on my desk. We were launching the malaria indicator survey early this morning that has shown 2% reduction in malaria prevalence in Kenya, marked reduction in the coastal and lake region area. But today, the invitation is to do with my other secondary role, chairman of the Deployment Task Force, a role that I've been holding from the beginning of this year in January, when I was tasked to bring together stakeholders to coordinate the introduction and deployment of COVID-19 vaccines task force. So it will be my pleasure to share with you some of the progress that we've done in this field so far, give you some of the current achievements and challenges, and discuss about our acceleration plans to ensure that we meet our targets. I will start with this trend analysis of COVID cases in Kenya, clearly showing the 4 waves, and really showing how the positivity rate has reduced in the last few weeks. This is good news, but for us, deploying the vaccine the danger we fear is that when people see such a reduction, they are likely to imagine the disease is over, and we may see a reduction in the uptake of the vaccine. So much as the wave is going down, it does not mean the vaccine, the COVID pandemic is over. It's and we have to keep the guard, including ensuring that we continue getting vaccinated. Some of the key points in terms of our targets, I really want to make it very clear that our target is to have 10 million vaccinations by the end of December, but to ensure that we fully vaccinate 26 million adult Kenyans by the end of next year. During the last 2 months, we now have, we are deploying multiple vaccines. We started with AstraZeneca. Moderna was deployed at the beginning of September. Later on in September, we started a deployment of Pfizer. We've also deployed Johnson & Johnson, and we've also deployed the Sinopharm made in China. I want to report that the global supply chain situation is improving and has actually greatly improved. We now have almost 8 million doses delivered. We expect 10 million by the end of this month. By the end of December, we project to have 14 million doses of these types of vaccines. And by the end of next year, 25 million doses. By June next year, 25 million doses. In fact, the global supply situation continues to improve every day. In this morning, we even had more coming. So unlike in the beginning when supply was a constraint, moving forward, that is now not our biggest worry. So just to give you a snapshot of where we are with the 8 million doses that have so far been delivered. As of this morning, we have now done 5,084,000 vaccinations. The first doses are 3.5 million, and now we have over 1.5 million Kenyans fully vaccinated. The uptake of the second dose has continued to improve and now stands at 40%. And at least you can now see movement in terms of the proportion of adults fully vaccinated, standing at 5.5%. This is a little bit an old slide. I was trying to update it before now, but this is about slightly over 6 weeks ago. When we compare with the rest of Africa, that time we had done 3.5 million vaccinations, but as I've said, now we are 5 million, therefore moving very close to most of the countries. And as you can see, the countries performing best are Morocco to the north, Egypt, and then South Africa. Now, we continued to have a phased approach in terms of our vaccine deployment. In the initial phase, which was March to June, you recall our target population was the frontline workers, who included healthcare workers, critical essential workers, and persons above 58 years of age. The target was 3.85 million, but as I said, because of limited supplies, we didn't achieve that target. However, from July, there's been an increase in the doses, and we expanded our age groups to include all persons above 50 years, persons above 18 years with comorbidities, and our plan was then to increase to those in 40. But as I've said, because of the improved vaccine supply, the task force is now really recommending that we may have to open vaccination to all age groups. This is a discussion that has been held, and I think the ministry is likely to endorse that. But our initial plan was to open this in January, but really now the vaccines are there. As you know, we have also started deploying Pfizer, and because it's registered for use in teenagers, we will be working with the regulatory body to see whether we can start vaccinating persons below 18 years earlier than we had anticipated in January. Now, this is something familiar again in terms of the mortality trends, in terms of age and sex, on the COVID morbidity. And the reason I'm praising it, because it has something to do with our vaccination prioritization. As you can see, persons above 60 years of age are the ones most afflicted. They're the ones dying. These were deaths as of last week, 5,223 deaths that had been recorded in the country. You see the 50 to 59-year-old follows, the 40 to 49, and you can see very few deaths in 0 to 9, 10 to 19. Of course, of interest, you see males are affected more. I think a good subject to explore why. Is it the men that go to places that they share air and are at most risk of transmission? I think that is still a subject of interest. Now, this is vaccination by counties. The county uptake has been a little bit worrying to us. There are some counties that have performed well. The first blue bar there, although the county name doesn't appear, that is Nairobi. In fact, as of this morning, Nairobi has over 16% fully vaccinations, which is really, really encouraging. You can see it's followed by Nyeri, Uasin Gishu, Kisumu, Mombasa. As we look at these county trends, although these are not all the counties, of great concern for us is densely populated counties in Western and Nyanza. They continue to have very few fully vaccinated people, and that definitely will have an impact in our achieving our targets. In addition, of course, the counties in the ASAL regions have also not been performing well, but now we have put efforts to really increase outreaches in those areas and see if there will be an improvement in uptake. When we look at vaccinations by age group, again, this is not what one would expect, but really can be explained. You can see that most of the vaccinations have been administered to persons 30 to 39 years of age, followed by those 40 to 49, and then you have the 50 to 59 and the 60-year-old. Now, the likely explanation as of this is during the first phase, our target were frontline workers, people working, people in the security sector, healthcare workers. Many of them are in the active age group, and that is why the uptake is likely to have been higher among these age groups.
Let me do.
When we look vaccination by priority groups, we now see that over 76% of health workers are now fully vaccinated. We have almost 100,000 security officers vaccinated. The uptake among teachers has picked up, and now almost 40% are vaccinated. The biggest concern we have, and going back to the slide that I showed where most deaths are occurring, is persons above 58 years of age. Only 13.5% of them now are fully vaccinated. Now, if we have to have an impact in terms of reducing hospitalization and deaths, this is the group that really needs to get vaccinated. I will give some of the ideas we are having to increase vaccination here, but call upon everyone here to see how we could better strategize to have this group fully vaccinated. Now, this is an old slide and I will not dwell on it. It is a pipeline as of where we are projecting, but the message is very clear. We will have more doses to reach our target by December. So doses are no longer our concern. So what are some of our acceleration plans? We plan to ensure that we increase our daily vaccination rates from 1,000 to 80,000 in September to 150,000 by December. We have seen some good progress in this. Last week, our best was 91,000 vaccination in a day. However, when it comes to weekends, most vaccination posts do not open, and it brings down our averages. We used to do 5,000 to 8,000 on a Saturday and Sunday, although this time we are doing 20,000 on a Saturday and 15,000 on a Sunday. But if we have to sustain this average per day at more than 80,000, then vaccinations need to take places within during the weekends. I'm happy to report that actually we have increased the number of vaccination centers beyond the 3,000 we initially planned. We are at 4,000 vaccination centers now, and we should cover all vaccination posts before the end of June next year. Outreaches, you've been seeing that in the media. You've seen us targeting specific populations for outreaches, including people working in the transport sector, in the hospitality sector, in regions of congregate settings like the prisons, National Youth Service. You've seen us really going there and ensuring. However, the point I want to make about those beyond 58 is our recommendations to ensure that when they attend their medical or surgical clinics, they get vaccinations there. The information we get from the elderly, many of them fear coming to hospitals from the fear of contracting COVID at the moment. We are currently scaling up our communication, especially through the use of vernacular stations. You've seen our change system that is sending reminders to people. And we are working with counties to identify local champions who are going to pass the message about the need for these vaccinations. The other key activity we are doing now, and is very urgent, is our expansion of the cold chain. As you know, we now have a capacity to store over 3 million doses of Pfizer that require -70 degrees. We already had storage capacity for -20 for Moderna, while the normal freezing, the normal cold temperature 2 to 8, we have almost adequate stores. The challenge, however, remains that this capacity is within Nairobi and the 9 regional stores. So there is a cost in terms of counties having to go to pick vaccines. The turnaround time for them to have vaccines at the facility has been a concern. And therefore, the government plans to set up 25 county cold rooms, walk-in cold rooms, that will then ensure that that is addressed. Finally, as His Excellency the President announced Mashujaa Day, there's been a formation of a company known as Kenya Biovax Limited, mandated with human vaccine manufacturing, and which is going to start with the establishment of a fill and finish plant. And by April or the Easter, then we should be able to have established a fill and finish, basically partnering with companies and establishments that already have WHO approval, and the country serving as a center that we do the final fill and finish and marketing. Thank you very much for listening. Just emphasizing that people would better listen to the message about vaccination. Thank you.
Thank you very much, Dr. Willis Aquale. We appreciate all the good work that you're doing. Thank you very much to that COVID-19 Vaccine Response Committee. We appreciate the work. I hope Dr. Willis will be.
Yes.
I hope you'll be able to stay on with us for the Q&A.
Yes, sure.
Fantastic. So next we'd like to have 3 abstracts. We'd like to hear what Machakos County is doing, what Nairobi County is doing the informal settlement, and there'll also be a presentation about the mental health in times of pandemic. So we'll start with Dr. Sharon Zawadi Mweni. Sharon, Dr. Sharon, are you ready? Thank you for continuing. Please continue putting your questions in the Q&A. I'm already seeing 2 questions for Dr. Aquale. I can see Sharon here, Sharon Zawadi Mweni. Sharon, kindly unmute and let us know if you're ready.
I'm trying to unmute.
Okay.
I don't know on my end if my screen is visible.
Yes, we can see your screen.
Hello?
Just put it on full screen.
Okay.
Thank you.
Yeah.
Yes, Sharon.
Should I proceed?
Yes, yes, please proceed.
Can I proceed?
Yes, Sharon,
Okay.
please proceed. Yeah.
Okay. Okay, thank you. Good afternoon, team. I'm Dr. Sharon Zawadi. I'm a medical doctor by training, and I also hold a master's degree of public health with specialization in epidemiology. I work at Machakos County Referral Hospital. So I'm going to present a study titled COVID-19 Preparedness and Response in Machakos County. Basically, this study is about the measures we've put in place in Machakos County
We seem to have lost Dr. Sharon. Sharon, can you hear us?
Okay. That is the Department of Health to respond to 2020 by WHO. The first case of COVID-19 in Kenya was reported on 13th March 2020. And by 10th June 2021, we had over 174,000 cases had been reported countrywide with over 3,000 COVID-19 deaths, and also with established community transmission in all counties, and that is according to the Ministry of Health Emergency Operations. So all counties have so far reported cases of COVID-19, cases of the virus, but the most affected counties in Kenya are Nairobi, Machakos, Kajiado, Kiambu, and Nakuru. It is also important to note that this report is per June 2020 to June 2029, so figures have changed. So the aim of the study was to assess the burden of the COVID-19 in Machakos County and to assess the proportion of people who tested positive for COVID-19 in the county, and to assess the number of people who died from COVID-19 in the county. So methodology, I'll start with defining the study area so that at least you can have a picture. So Machakos County established 4 COVID-19 isolation facilities to manage moderate to severe COVID-19 disease. And one of them is the COVID-19 ICU that is located within the Machakos County Referral Hospital. And then the Stadium Screening and Isolation Center, which is the field hospital. It is located at the Kenyatta Stadium. The stadium, those who've been in Machakos County, we have a big stadium. That's where the field hospital is located. And it is within the Machakos, Machakos sub-county. Then we have the Kinani Isolation Center. This one is located in Athi River sub-county, and the Kangundo Level 4 Isolation Center, which is located in Kangundo sub-county. So the 3 isolation center, that is the field hospital, Kinani and Kangundo Level 4, those ones are for managing moderate COVID-19 disease. and the ICU for managing severe disease. And then the other study area is the mobile COVID-19 testing laboratory. So a bit further on the study area, that is the bed capacity. So for ICU, for Machakos Level 5 COVID-19 ICU and the ward, we term it as one isolation center. So maybe you might ask why I said 4 and now I have 5 in my list. So ICU has an 11 bed capacity. The ward has a 13 bed, and Kangundo Isolation Ward has 14 bed capacity, Kinani 12, and the stadium, the field hospital is the one with the largest capacity, 340. So in terms of isolation centers, Machakos County, we have 410 beds managing moderate to severe disease. So for those who've not seen the field hospital, maybe on social media, you haven't been to Machakos County, I thought I should put the picture so that at least you can relate. So the COVID hospital is located at the Kenyatta Stadium, and it's actually 2 tents, male and female, with a capacity of 170 beds. So you can see even the interior, how the beds are, they've been placed. There is a table in between and a distance from one patient to the next. And then this is the COVID-19 mobile testing laboratory that has 2 entrance and exit, where one is for the patient and the other one is for the clinician. So in terms of the meeting for the patient, this clinician, hardly the separation of a glass in between. So the study design, we did a cross-sectional study that was conducted from June 2020, the study period, to June 2021. And this was to review all the files of patients diagnosed with COVID-19 and admitted in the 4 isolation facility, and also to review the registers of patients screened and tested at the mobile COVID-19 testing laboratory. So we described the number of patients, those that were screened and tested for COVID-19 at the medical laboratory, and also the COVID-19 positive patient admitted at the 4 isolation centers. That is the socio-demographic factor, as well as their associated mortality and recovery rate. So after analysis, our results, what is being seen on the screen is a graph on admission status per isolation centers. That is the 4 isolation facilities, and you can see the color coding. The total admitted number of patients is blue. Then we have the mortality in gray and the recoveries in orange. And Machakos level 5 ICU is the one that had the highest admission of 345. These are also, I should state, their absolute numbers. And a recovery rate also, it had the highest of 203, and also had the highest mortality, followed by the field hospital, and then lastly was Kinani. Then this is the mortality and recovery rate per facility. So ICU, you can see the mortality was quite high, 36%. And this is due to most of the patients admitted in ICU. There are patients who are very sick, and most of them come late. Also, at that time, there were also issues of most of COVID-19 ICU in the country were at full capacity. So we ended up losing patients. At the stadium, the recovery rate was quite high at 98%. And at Kangundo, it was 76%, and Kinani, 95%. So in total, the whole Machakos County, for the 4 isolation centers, we had a recovery rate of 77% and a mortality of 23%. That is for the period of June 2020 to June 2021. And for the mobile laboratory testing, whereby we were reviewing the records of the patients who are were screened and tested.
I thought
Sorry. Okay. So for the mobile testing, those are also absolute number you can see on my x-axis. Sorry, you have to twist your neck a bit. So on my x-axis, those are the number of the clients screened and tested, and on my y-axis is those who are positive and those that were screened, and you can see out of 1,253 screened, half of them were positive. And on my left side, it's the interior of the mobile COVID-19 laboratory clinic, and you can see the clinician is on the other end, and there's a glass separating the two. That is the client and the patient. It's sort of like a hood whereby the clinician and the client, there's no contact, so the risk of exposure is quite low. And down there, it's on the other side now of the clinician. This is a colleague working in the laboratory in the lab, and has given me a consent to share her photo. You can see the reagent on the other side. So in conclusion, so cumulative, we had a total of 716 patients who are COVID-19 positive and admitted in the 4 isolation center for the period of June 2020 to 2021. And we had a mortality rate of 23 and a 23% recovery rate of 77%. So in conclusion, setting up appropriate treatment facility, that is isolation center, that is early, at the earliest time possible at the county, is key in the management of COVID-19 patients. So that brings to the end of my presentation. Thank you. I invite any question, concern, addition, and omission.
Thank you very much, Dr. Sharon Zawadi. Thank you for that clear presentation. And we like what you're doing. We like all the support the counties give to this pandemic. Next, Sharon, the questions, we hope we'll answer them all together at the end of the session. So next we'll have Leah Adhiambo Nyasuna. I can see Leah is here with us.
Yes.
Kindly remember to put your questions for Sharon in the Q&A section. Leah, are you ready to make your presentation?
Yes, I'm ready. I requested the team to project.
Great. So Leah will be telling us about mental health in the times of the pandemic, abstract number 52. She'll be telling us about what she found on the ground. So give it a few minutes for it to be projected by the team.
Okay, no problem.
Okay, and immediately after Leah finishes her presentation, we'll have Beat Ringwald. Beat, I hope I'm pronouncing your name correctly. Beat Ringwald will be telling us about the effect of the COVID-19 pandemic on community-based participatory research. It will be a reflection from a study in the informal settlement in Nairobi, Kenya. And after that, we'll proceed to the Q&A section for this session. Leah, you can go ahead. Your presentation is on the screen.
Good afternoon. My name is Leah Nyasuna, currently a master's student at UoN, doing health economics and policy. I'll be presenting on mental health in times of COVID. Thank you. Introduction. Our economic meltdown is a carryover of the advent of the disastrous COVID-19 pandemic, which have in so many negative ways dented the mental health of several Kenyans, giving rise to new predicaments and challenges for people already dealing with mental illness and substance use disorders. During the pandemic, a mental health task force was formed that brought into light some reports that shows that About 1 in every 10 people suffer from a common mental disorder, and 1 in every 4 patients attending regular outpatient services has a mental disorder. Among the mental illness diagnosed in Kenya, depression and anxiety disorders are among the ones leading in number, followed closely by substance use disorders. Research indicates that 25% of outpatient and up to 40% of inpatient health facility visits have diagnosable mental health conditions. Research have additionally found that many adults are reporting specific negative impacts on mental health and well-being, such as difficulty sleeping, we have 36%, eating 32%, increase in alcohol consumptions or substance use 12%, and worsening chronic condition 12% due to worry and stress over coronavirus. This basically means that since the pandemic hit us, so we have had, increase in several mental illness conditions. Like we are having people having difficulty in sleeping, eating, even increase in alcohol use because of the fact that they are worried over coronavirus, or they're basically just having stress over it. As the pandemic wears on, ongoing and necessary public health measures expose many people to experience situations linked to poor mental health outcomes such as isolation and job loss. So basically, there are so many people who have, been affected negatively by the pandemic. And so because of that, there are issues of job loss that are leading to stress that, suddenly leads to mental health disorders. The youth have recently undergone through several COVID-related impacts, some including abrupt closure of universities and sudden loss of jobs, that which certainly can lead to strained mental state. Just because these activities are sudden, it gets to a point where people can be stressed, especially the youth. Statistics have shown that more than 50% of young adults ages 18 to 24 report symptoms of anxiety or depressive disorder. That is about 56%. If studied in comparison to all adults, young adults are more likely to report substance use, 25%. That's for the young adults versus 13% to all adults. And suicidal thoughts, that is 26% versus 11%. So this just shows that young adults are more at risk of mental health disorder. Before the pandemic, young people were already at high risk of poor mental and substance use disorder, though many did not receive treatment. Research from prior economic downturns shows that job loss is associated with increased depression, anxiety, distress, and self-esteem, and may lead to higher rates of substance use disorder and suicide. During the pandemic, adults in households with job loss or lower incomes report higher rates of symptoms of mental illness than those without job or income loss. That is 15 versus 32%. It just shows that people in households where jobs were lost or incomes were reduced, they experience many symptoms of mental illness. Research during the pandemic points to concern around poor mental health and well-being for children and their parents, particularly mothers, as many are experiencing challenges with school closures and lack of childcare. Women with children are more likely to report symptoms of anxiety and depressive disorder than men with children. In general, both prior to and during the pandemic, women have reported higher rates of anxiety and depression compared to men. That is at 49 and to 40%. Women are experiencing 49% compared to men at 40%. Just shows that women are more worried, about children, especially the ones who close school. They're worried about how they're going to eat, how are they going to be taken care of. So you find that women are more affected, even were more affected during the pandemic because a lot was happening. Kids were closing school and they were finding themselves in a situation where they were not able to provide. Throughout the pandemic, anxiety, depression, sleep disruption, and thoughts of suicide have increased for many young adults. They have also experienced a number of pandemic-related consequences, such as closure of university, transition to remote work, and loss of income or employment that may contribute to poor mental health. Basically, what I already said, meaning that, there are so many things that happen just because of the pandemic, loss of work, loss of income, that have affected the young adults. And you find that most of them were experiencing so much anxiety and depression to a point where their sleep was also affected. Given the substantial anticipated burden of mental disorders in the given context of the COVID-19 pandemic, mental health responses should be given high priority. Yes. Statistics have shown that more than 50% of young adults ages between 18 to 24 report symptoms of anxiety and depressive disorders at 56%. If studied in comparison to all adults, young adults are more likely to report substance use, that is 25 to 13%, and suicidal thoughts. Before the pandemic, young people already, I think we have already touched on this. Could you please go to the next slide? Thank you. Low awareness of mental disorders, particularly the symptoms, remain one of the biggest challenges in Kenya. As a result, mental illness continues to be marred by myths and misconceptions. The fact that people are not really aware that mental illness can actually really affect an individual, or even the judgment that is around it, the stigma, it just makes it difficult for individuals who are experiencing mental health. Some communities view it as a curse, witchcraft, spiritual problem, rather than a disease like any other that can be professionally treated and managed. Yeah, we need communities to be sensitized that anyone experiencing mental health, it's okay, and they need to understand that it's like any other disease, so that the stigma is reduced, so that people can come out and say, yes, I'm experiencing a bit of anxiety, I'm depressed. Yes, so when people are aware and they are told the importance of just accessing even help in terms of treatment, then it becomes less of an issue, or at least well managed. This calls for strengthening of mental health education and training young people in and out of schools on how to seek help. Yeah, so basically for young people and even for adults, basically, it's there's need for, strengthening that awareness, sensitization. Where can I get help? What can I do? What does it mean when I'm experiencing anxiety or I'm depressed? How do I cope with this issue of alcoholism? Yeah, so there's just need for more awareness, and even centers for accessing this kind of mental health services. It also calls for more education on communities to deal with the stigmatization that affects mental health. Training of more mental health personnel to be distributed in various health facilities, also critical in mitigating the challenge. Yeah, stigma itself is a big thing, because if I'm stigmatized, then it becomes, I can't even talk about it. I can't even say that I'm experiencing, anxiety. I can't even say that I'm depressed, because there's so much stigma that is surrounding mental health. So I'll just stop there, and I hope that a lot more will be done to help in the area of mental health. Thank you so much. I really appreciate it.
Thank you, Leah, and thank you for that presentation. And yes, I agree with you, mental health should be given a priority. Thank you for that. I hope you'll stay on for any questions that will come up out of your presentation. Our final abstract for this session before we get to the other session is from Beat Ringwand. Is Beat here with us? Okay, Beat was supposed to talk to us about the effect of COVID-19 pandemic on community-based participatory research. And this was a reflection from a study in the informal settlement in Nairobi, Kenya. And this would have been a very good study to hear, or be interested to hear the findings. So if Beat, you're here, kindly let us know so that we get to hear your presentation.
Good afternoon. Can you hear me?
Yes, we can hear you.
Wonderful. Yes, once more, good afternoon. My name is Beate Ringwald. I'm a PhD candidate with the Liverpool School of Tropical Medicine. Today, I'm presenting lessons from our study that we did in Korogosho, an informal settlement in Nairobi. It's a participatory study on intimate partner violence and HIV, and I'm talking on behalf of the entire research team. A bit of background. Participatory research is essentially about involving people affected by the study topic, in this case, HIV and intimate partner violence, in the study as lay researchers throughout the research process. The COVID-19 pandemic disrupted research in general, but participatory research in particular, because the vulnerable or marginalized groups of people needed to be involved, and that became more difficult. Many studies moved their activities to digital platforms or use digital methods, but that was not possible for us operating in an informal settlement, because people need to be computer literate, need to have access to gadgets, need to have stable network access. So today I want to reflect on the pandemic and its effects on community-based participatory research and on communities, and with a specific focus on our study. As I said, it's a community-based study on the prevention of HIV and intimate partner violence in an informal settlement. We worked in Korogosho in Nairobi. The pandemic reached Kenya when we were at the community entry stage, and that's where we halted our study in March and stopped all activities until more and more reports emerged about the pandemic-related increases in domestic violence, and we realized that we actually had a role to play in continuing with the study and supporting community in preventing intimate partner violence. We amended our protocol. It was approved by ethical review boards in the UK and in Kenya, and we resumed our study in August 2020. I was based at LVCT Health, an HIV service provider in Kenya, and I think that was a conducive environment to think through ways of safely resuming the study, because as an organization, LVCT Health also had to think about safe ways of continuing providing HIV testing, counseling, and treatment services. So in August 2020, we resumed the study and formed a research team with Kenyan European researchers. And sorry?
We can't see the screen. Are you projecting?
Yes, you can't see my screen.
No, we can't.
Oh, I'm sorry for this.
What?
Can you see my screen now?
Yes, yeah.
I'm sorry, let me just jump back so you can see. You haven't missed much. So that's the screen, the title. That was the background. Now we're here. Sorry for that, the inconvenience. So we formed a research team of 4 with researchers from Kenya and myself, and then 11 community co-researchers from Korogosho. And we collected data in November, December through focus groups and key informant interviews. We did, here you can see on this slide, the actions we took to mitigate the risk of infection during study. So we amended our research activities. We did not have a community entry meeting, but we had one-on-one stakeholder meetings. We reduced the number of participants. At every research activity, we informed about COVID-19. We did body temperature checks, provided hand sanitizers and face masks. Co-researchers could refill their sanitizers at every meeting. We promoted physical distancing, excluded sick participants, and reviewed our protocols regularly. What we learned was that COVID-19 amplified the existing inequalities that are there between informal and formal settlements and within the informal settlements. It was both an observation, but we also had to navigate actively these inequalities. We had weekly visits to the study site from August 2020 to July 2021. As researchers, we regularly debriefed, shared our observations and reflections as outsiders from formal settlements working in Korogosho, and we discussed the impact of COVID-19 on the study and the community with our co-researchers. So that's our sources of data for these reflections. We worked in an environment where it is and was very difficult for people to observe the general pandemic control measures of physical distancing in overcrowded dwellings, washing hands regularly when a water supply is irregular, using face masks when you have lost a job and your source of income has dried up. So it was difficult for people to follow the infection control measures in that context, but still they appreciated our study protocol and followed it, which was good because we weren't sure whether this would work. But people appreciated that we provided masks, they sanitized, and they tried to keep distance. By providing information, we helped clarify misconceptions about coronavirus. So in the beginning, it was seen as a disease of the rich and that Africans were immune. So we could clarify that and explain that in general, everyone is at risk of infection. Most of us were parents or are parents in the research team, but we observed that co-researchers and researchers had very different concerns. or there were substantial differences in our concerns. We were all worried about the future of our children, but the children of our children as researchers, they continued with education online, and children of co-researchers or in the community in general, they were out of school. We worried about our children not being able to play with other children, or about academic performance, while the worries of co-researchers and the community in general were more substantial. It was about boys joining gangs, girls getting pregnant, children dropping out of schools, children resuming to drug use and alcohol use, engaging in early sex. So very substantial worries about the future of their children. I think Leah in her earlier presentation had talked about the mental health impact on young people, and I think that resonates well. When the schools were reopened after 10 months, that was in January 2021, that was a big relief for us as researchers. Our children went back to school, and we thought we can now accelerate our study and continue with data analysis and finish that by Easter. And when we reached the community, we realized reopening of school was very stressful for co-researchers, and we could not actually accelerate, but had to slow down our data analysis process and adjust our pace to the space that community co-researchers had to engage with the study. Finally, the study protocols put to test. Till March 2021, COVID-19 was kind of a distant disease to most of us. But then in March 2021, there were first official infections in Korogosho, and also one of our research assistants was admitted in hospital with COVID-19. I say that was a test for our protocol because it was only one person in the research team having tested positive for COVID-19, and others did not fall ill, although we had met regularly every week. The second lockdown interrupted our data analysis, and we had to think of new ways of working together so that we continue with data analysis. And we resorted to remote meetings in small groups of 3 people, then connect virtually via Zoom, so that the co-researchers continued to work on data analysis with minimal support. And that was a test to our participatory approach to hand over even more control to co-researchers and entrust them with working independently. In conclusion, community-based participatory research is possible to be done face-to-face during a pandemic. What needs to be considered is the risk of conducting or not conducting the study and the risk of infection. Evidence-based measures can be adopted to mitigate the risk of infection during research activities. The circumstances and social power of co-researchers and researchers need to be considered to mitigate harm to people involved in the study and the community. And it's necessary to regularly review and adapt protocols in view of dynamic pandemic situation. I would like to thank the conference organizers for giving me the chance to speak today and to participants to listen. Also, many thanks to the Korogosho Alive co-researchers. And if you have time, look at our posters where we share about the risk of intimate partner violence and HIV and how that increased during COVID-19 pandemic, or look at any of our links. Thank you so much for listening.
Thank you very much, Beata, and please accept my sincere apologies for mispronouncing your name at the beginning. Thank you for that presentation. That was
No
really
worries, thank you.
great. I hope you'll stay on for a few questions, if there are any that should be raised in the Q&A section. We are a few minutes past our time, but let's quickly just jump into the QA session. And I can see Dr. Aquale has responded to most of the questions that have been raised, and most of them were relating to vaccine hesitancy and acceptability, and he's done a remarkable job. If you feel there is a concern that has not yet been addressed, kindly let us know. But Dr. Aquale, there's a question by Jacob Kipchilis, and is asking whether we've involved religious leaders. The strategies that you mentioned or proposals, and this included opening on weekends, having outreaches, max vaccination centers, using of vernacular FM stations, the Chanjo system, and local champions. So are the religious leaders part of the local champions that you're hoping to involve or include this? And just to add on, are we planning to also do this in political rally drives? Next year will be a lot of campaigning going on. Are we also planning to incorporate part of those the vaccination programs in that campaign drive season?
Okay, good question. Thank you, Chair. I will answer that, and I can see Sarah Obara has also asked a question, then respond. Now, the issue of political mobilization for vaccination is an important one, but it will be best done by politicians. I, standing in a political platform, I won't even know how to begin a speech and then now go to vaccination. However, if any of you have been following the political rallies going on, I think the word vaccination is very foreign in those rallies. While I would imagine it should really be the beginning so that we mobilize as many Kenyans to be vaccinated and be sure that the coming waves will not interrupt with at all with the electioneering period. So for me, it's a good challenge. It's a challenge we must take to politicians. They must really look at this as a very key to securing a successful election, because if in the next 3-4 months we get epidemics like we saw in India, then obviously there will be a very big challenge. So my simple answer is yes, we would want to urge the political leadership to make vaccination a key discussion agenda beyond just registering as voters. You may be registered, you are not vaccinated, you are at risk of severe disease and death. So let me leave it there, but any opportunity, me and any other person meets politicians, I think that's the message. Now let me come to the issue of Interfaith Council. At the national level, we have involved the Interfaith Council, we meet them. They're actually among the people who really challenge us on what we need to do. And they have branches within the counties. They have mobilized those branches as well. In fact, they were very key in allowing us to start using places of worship for vaccination. And you've seen an increase in that happening. In terms of sustaining our drive, in terms of mobilization, I'm happy to say that actually we are going to discuss with them a lot more and hopefully get as many places of worship serve as vaccination centers. Now that the places of worship have been opened for more people to attend, that means more people will be going to churches and mosques. And really that will be very ideal to conduct vaccination over the weekends when we are seeing our numbers being low. Now, there's then the question by Sarah Obara about persons aged 58 being, we may need to consider using a social behavior change model to establish barriers and how to overcome them. I welcome that, but I also really would want, because we are in a pandemic and we want to vaccinate as quickly as possible, some of the immediate barriers that are being identified, if counties could quickly address them, We were in Trans Nzoia, and one of the things they told us, old people feel nowadays hospitals are just full of COVID. So on their part, the solution they are using is community health workers organizing specific or targeted outreaches for the elderly people close to the homes. But I'll be happy to learn more about the behavior change, and the team in my task force dealing with communication should be in a position to deploy that. Thank you.
Great. Thank you very much, Dr. Aquale, and we appreciate the work you have done over the last few months, both phase 1 and phase 2. And now, even as we plan to move to phase 2B, we appreciate that. You started at a point where there was a lot of uncertainty and misconceptions associated with the vaccine, and just to see that we've achieved 5.5% of adults fully vaccinated, we don't take that for granted. To your team, tell them asante sana. And we hope that the target you've given yourself, which is quite an uphill target, you'll be able to achieve it by December, the 10 million vaccinations and 26 million adults vaccinated by end of 2022. So thank you very much for that. And my next question will be to Leah. Leah, there's a question about using technology to solve mental health issues. Can we solve mental health using technology? I don't understand the question. Whoever posted the question, could you mind clarifying a bit? What are you talking about? Diagnosis? Are you talking about assessment? Are you talking about treatment? What aspect are you referring to when you ask about, can we solve mental health using technology? How can we do that? So kindly please clarify your question. We will appreciate that clarification. I'm seeing 2 raised hands, so I will, there's Martin Ouma and Dominic Elema. Kindly ask your question or make a comment quickly so that you can move on to the next session. Okay, Dominic Elema, would you like to say something? Your hand is raised.
Hey, cheki. Ebu jaribu kujoin na ile link ulinitumia.
Apologies for that.
Okay. So nimetumiwa link ingine na nimejoin kama Linda.
Okay, apologies for that. So thank you very much. I'd like to thank all the presenters, the lead speaker, Dr. Willis Aquale. I'd like to thank Dr. Sharon Zawadi Mweni from Machakos County. I'd like to thank Leah Diambo Nyasuna and Beata Ringwald for the great work that you presented. We appreciate all the effort you put in to get that data and to come and give us scientific evidence-based research and work that you've done. We appreciate your teams who supported you, and we also appreciate the organizers of this forum or this conference. Allow me to hand over to the next moderators so that we also don't take so much of their time. Professor J. Oyugi and Dr. Sylvia Opanga, please take over. And thank you all for listening to us. We appreciate it. Thank you.
Thank you very much, Dr. Kalondu, for the wonderful moderation. So this session is going to move slightly from COVID, but we'll be tackling other infectious diseases. So welcome to the session. Our first presenter will be Benea Apollo Obanda, and she will be presenting on the molecular epidemiology of Staph aureus in humans and animals in Busia County, Kenya. So please, Benea, you can share your screen and proceed. Are you there? Kindly confirm that you're there.
Yes. Not coming up. Actually, let me leave.
Yes, if you're there, Apollo, please confirm your presence so that we can move on.
Vanya was unavailable unless if she had sent somebody else to present on her behalf.
Okay, then as we wait for that clarification, I think I'll go to the next presenter, who is Odor Michael Ochieng, and he will be presenting on exploration of staph phages for therapeutic and biocontrol purposes. I hope Odor is around. Odor Joseph Michael. Well, we seem not to have that presenter as well. So once they come in, I will slot them in. So I'd like to go to the presentation by Angela Makumi. I think Linda is available to present it. Linda, kindly share your slides and proceed.
Good afternoon.
Good afternoon, Linda. Could you kindly
hear
put your
me?
presentation on slideshow? Yes, we can hear you.
Okay. My name is Linda Guantai. I'm a research associate at the Animal and Human Health Department in ILRI. I'll be presenting on the use of bacteriophages to revert antibiotic resistance in bacteria, the phage antibiotic synergy phenomenon, on behalf of Angela Makumi. Zoonotic strains of Salmonella include Salmonella bredenram, Salmonella bredenberg, Salmonella enteritidis, Salmonella typhimurium, Kentucky, and Coleoriasis. These strains are known to infect both animal and humans, and the increased abuse and misuse of antibiotics in animal farming and human health care has led to an increased antimicrobial resistance occurrence. So why are we concerned about the increased antimicrobial resistance? It is projected that by the year 2050, it will result to 10 million deaths, which are more deaths even compared to other infections and diseases such as cancer. Therefore, there's a need to develop alternative antimicrobial agents such as bacteriophages. Bacteriophages are viruses that specifically infect bacteria. They were co-discovered by Felix Dierel and Todt in 1917 and 1915, respectively, and since then have been used in several clinical practices such as dysentery treatment. Phages have both narrow and broad host range. For phage therapy, lytic phages are used because they attach to a bacteria host, insert the genetic material, multiply, and then are released. During the release, they cause the death of the host. They have several advantages over antibiotics, such as the ability to autodose because of the self-amplification of the phage. They have low toxicity, absence of cross resistance. They are relatively cheap in manufacturing, and they do not infect mammalian cells. In our study, we visited 57 farms and 4 slaughterhouses in Kiambu and Nairobi. We screened 631 samples for Salmonella and phages. 7 farms had Salmonella, and the total number of Salmonella phage positive samples were 435. CRISPR typing was used to confirm the Salmonella strains circulating in the farms, such as Salmonella enteritidis, Salmonella Kentucky, and Salmonella Heidelberg. We extracted Kenyan crude lysate phages using the spotting method on a double agar layer plate, and it was good to note that 10% of the crude lysates, the highest percent of the crude lysates were obtained from Kiambu County. That is, from the graph on the right, around 60% of them were obtained from Kiambu County. We obtained, in general, 88 crude lysates, and after purification, and because some of the phages also lost viability, we remained with 41 phages. On the left, the phages exhibited here were only we tested their host range, and they were the host pattern, and these phages were only lysing Salmonella enteritis. The dark columns indicate the phages killing the specific Salmonella isolates, except some phages here that are on the lighter side here that were not killing Salmonella 312 and Salmonella 73. We noted that Salmonella 73 190 phage had a different host range pattern. The 39 phages were further characterized by restriction fragment length polymorphism using ECOR5 enzyme to determine the different diversity of the phages. We obtained 13 phages that exhibited different restriction patterns, and these were selected and used for further characterization. The lytic capacity in broth of the 13 phages was tested on these two Salmonella isolates, number 73 and number 568, which were Salmonella enteritis. And 568 had earlier on shown that it could be killed by most of the phages, but upon following in time, we noted that some phages, such as Salmonella 73 190 here, the green one, was not killing Salmonella 568. But once we tested that phage on Salmonella 73, it was reducing the bacterial load within 1 hour at a high rate. This indicates that different phages have different killing efficiencies or capacities on different hosts. So far, we have potentially proved that phages can kill bacteria. However, we noticed that some bacteria were not being killed by phages. This is because frequent exposure to specific phage strains might lead to the development of bacteriophage insensitive mutants. There are several mechanisms by which bacteria become insensitive to phages, such as restriction modification, endonucleases, CRISPR-Cas system, mutation or loss of cell receptors. On the left, there's a plate on the higher right, that had some colonies that were not being affected by the phage. We picked these colonies and subjected it to phage 177 for 59. And as you can see, there's a wild type here that is being killed and a mutant that is not being killed by the specific phage. So this is how we confirmed our bacteriophage insensitive mutants. So how do phage and antibiotics synergize? There are several mechanisms by which an antibiotic attaches to a bacteria, one of which, an example is the use of efflux pumps as receptors. If a phage uses an antibiotic efflux pumps, it can select for phage-resistant bacterial mutants with impaired efflux pumps. These phage-resistant bacterial mutants become more sensitive to antibiotics. There are several data on the synergistic effect of phage antibiotic combination, and it has been proved that they work on several organisms such as Escherichia coli and Pseudomonas aeruginosa. We carried out antimicrobial sensitivity testing on our field Salmonella isolates. From this data, we got isolates that were resistant to drugs such as nalidixic acid on the left. The graph here shows the susceptibility profiles of isolates before subjection of phages. So These isolates were confirmed that they were resistant to some drugs such as nalidixic acid and gentamicin. We picked these isolates and exposed them to 2 phages separately and picked the isolates that were also insensitive to phages. These isolates were then tested again for their sensitivity to antibiotics. The graph on the right shows the sensitivity profiles of the multi-drug resistance beams to these specific antibiotics. As you can see, right now, the ones that were resistant before, they are now susceptible. This shows that these isolates are now susceptible to all antibiotics, including the ones that they were resistant to. This potentially proves that synergistically using antibiotics and phages could reduce the occurrence of antibiotic and phage resistance. In conclusion, ability of phages to select against antibiotic resistance in the bacteria indicates that combining phages with antibiotics can steer an evolutionary trade-off of phages with antibiotics. Bacteriophages can also offer a complementary effect by dropping the minimum inhibitory concentration for antibiotic resistance bacteria. We are yet to carry out further tests on the burst size of the phages, and we intend to do receptor characterization, the effect of sublethal concentration on combination therapy, pH and acid stability of our phages. I want to acknowledge Dr. Nicholas Civitek and Dr. Moses Masika, my supervisors, Dr. Angela Makumi, Josiah Odaba, and Amos Muhoni. I also want to acknowledge IDRC as the funders, UK Aid, Department of Health and Social Care, CGIR, and International Livestock Research Institute. Thank you.
Thank you very much, Linda, for your presentation. We are going to move on to the next presenter, who is Joseph Ganda. And Joseph is going to present about seroevidence of zoonotic viruses in rodents and humans in Kibera. Ganda, are you there?
Yes, I'm there.
Kindly share your screen.
I'm waiting for Linda to, okay, thank you. Is it there?
Yes, we can see it, but you need to put it on slideshow.
Yeah. Thank you. Good afternoon, everyone. I'm Joseph Ogola. I'm currently a PhD student at the University of Nairobi, KAVI. So I'm going to present part of the work that I'm doing. And as you have been told, the title is on seroevidence of zoonotic viruses in rodents and humans in Kibera informal settlement in Nairobi. So a bit on introduction. We know that rodents are actually a reservoir for a number of zoonotic pathogens, and these pathogens can spill over to human beings. And a unique feature about rodents is that they live in close association with humans. And more importantly, we have the commensal rodents, which are basically found in the urban settlements. They are well adapted species in urban areas, purposely because they have rapid reproductive cycles. They also have fast maturation rates, and urban areas also provide shelter and food reserves for these rodents. So they're able to multiply in large numbers, making their control very difficult. And also rodents, they have this high density reservoir population, which can basically lead to high diversity and pathogen prevalence. So why did I do this work? There's been an increase in the urban informal settlements, more so in low and middle income countries. And some studies, though, have been done to investigate urban rodents and their pathogens. They have only been done in major cities, like in New York. But in low and middle income countries, there are few studies on the zoonotic viruses that they carry. So little is known about rodents in informal urban settlements, though they are there. And also we know that in urban, in informal settlements, there is also lack of public awareness on health issues among the inhabitants in terms of accessing healthcare in those areas. So our study area, which is Kibra, it's known to have a large population of rodents. You can see on the picture on the right-hand side, the nature of the environment, which is very conducive for rodents to proliferate in large numbers. And also the information on the viruses that they carry and whether they spill to human beings is also lacking in this area. We also know that there are a number of undifferentiated febrile illnesses that have been reported in these areas, and we don't know whether rodent-borne zoonotic pathogens are contributing to this. So the methods how we did the study, we trapped rodents for a duration of 10 days in 2019, and we trapped around 300. We had a total of 300 traps across. We divided the area into five focal areas, and in each area we had around 60 trap nights. These rodents were then transported to University of Nairobi, where we were able to anesthetize them using isoflurane, and then we were able to get terminal samples. For the human samples, we involved 3 health facilities in Kibra in February to June 2017, basically focusing on febrile patients who had gone to seek medical care. And for those who were able to fit within the criteria, study criteria, we sampled for antibodies. Blood samples were collected, and we were able to sample for those antibodies against 3 viral groups using immunofluorescent assays, that's IFA. And for the conjugate, we used both goat and human IgG for humans, and then for rodents, we used goat and mouse. We know that the assays that we used were actually not specific, and they were also able to cross-react closely with other related viruses. So for the results, for the rodents, we had 2 species of rodents that we were able to trap, that is musculus and ratus. And in terms of zoonotic pathogens, we were only able to get orthopox viruses, and the prevalence, the seroprevalence area is indicated there. For musculus, it's 2%, and for ratus, it was 10.9. The overall seroprevalence for orthopox viruses was actually 4.1. Then we were also able to look at the proportion of these seropositive rodents across the regions that we were trapping. And actually some level of variation. Some areas reported high seroprevalence compared to other areas. For example, in Lindi, that is trapping zone 4, we were able to trap at the dump sites, and these are areas where people usually go, and also at the household level. And you could see the prevalence was actually high in Ratus species, 37.5. At the household level, the same, it was also high, 12.5. In overall, the prevalence was varying in different regions. For the human samples, the same applies. We were able to observe that for orthopox viruses in Kibra Community Health Center, the prevalence was high, which is 5.7 for orthopox, and it was also relatively high for Pumula hantavirus, which is 7.5. And also in Ushirika Medical Clinic, the prevalence was also relatively high at 5.7. And for Dobrava virus, we also had high prevalence of 5.9. And for Kibra South Health Center, you could also see that there was some high prevalence for arenaviruses. So what did we conclude from this work? From this study, we were able to report presence of antibodies against all the three virus groups, that is orthopox, arenaviruses, and hantaviruses. We also note mismatches between their presence in rodents and in humans. So for rodents, we were only able to get orthopox viruses, but in humans, we were able to get the three groups of viruses. The overall prevalence for orthopox viruses in the captured area, we had rodents and humans. They almost had the same seroprevalence. And there was also a clear difference in terms of prevalence among the different sites. And as I mentioned, zone 4 appeared to have high prevalence. Both zone 4 and 1, which had high prevalence in rodents, were also able to record high seroprevalence among patients in those facilities. We detected antibodies against hantavirus and arenavirus in humans, but not in rodents. Though our trapping focused on urban settings, where we mostly get those two species, we were of the opinion that other species might be in the same locality, though we were not able to trap them. And that's why we were able to get those viruses in human beings. So we also note that in Kenya, previously, arenavirus has been reported in Western Kenya. And we also know majority of Kibra residents also originate from Western Kenya. So there could be a possibility that those who are having those viruses might have also contacted them elsewhere outside Kibra. And we also note that the reaction to both Pumula and Dobrava, Belgrade, could be an indication of exposure to a different African hantavirus, because none of those patients reacted to the two different hantaviruses. Even though the test that we employed did not identify the specific viral species due to broad cross-reactivity, but it gave us a point, an evidence of infection to those three viral groups, that is orthopox viruses, arena, and hantaviruses in humans and commensal rodents. And therefore, more research is required to characterize these viruses precisely. So this work highlights the risk of rodent-borne viruses in humans in urban informal settlements. I want to acknowledge the people that we have worked with, my supervisors, Professor Omwanzala, Professor Oli, Professor Philip Nyaga, and Taria, and also Dr. Chris. I also acknowledge those who have funded this study, and thank you.
Thank you very much, Joseph, for your presentation. We'll quickly now go to question and answer. Don't leave just yet, Joseph. Linda, I will also invite you to stay for the Q&A. So looking at the Q&A session, I cannot see any questions for you, Joseph, but there's a comment in the chat about Linda availing the slides because your presentation was very interesting. And now I have one question for you, Linda. Could you kindly tell us, I'll come back to you, Maria. Could you kindly tell us what the implication of your study findings are and how we can apply the use of bacteriophages, particularly in combating antimicrobial resistance, and if there's any safety studies that have been done regarding the same. Linda?
So the implications on the study, what we're trying to do is we're trying to reduce antibiotic use in animals. So if we can come up with farmers trying to use less antibiotics, like the minimum inhibitory concentration, or reduce the spread of antibiotic resistant bugs from animals to humans, and also try to use more natural biocontrols, that would actually help in the bigger scope of mitigating AMR.
Thank you very much. Now, on the safety of the bacteriophages.
Yeah, so the thing about when you're using bacteriophages, this is just one of the starting points we have established, and we're yet, so the further things would be to sequence the phages that we're going to use for product development to make sure that they don't have any toxins, or they don't also carry antibiotic resistant genes, or they are not spreaders of resistant genes from one pathogen to another.
Thank you very much.
Ideally, they are safe and they don't actually infect mammalian cells, but however, they do interact with mammalian cells.
Okay, thank you very much for that. In fact, my comment will be that's a very nice area to reduce the rampant use of antibiotics, and it will really help in the reduction of the rate of resistance. Ruth had raised her hand. I think Mary came first, and then Ruth. Kindly unmute yourself and ask your question. Ruth, could you unmute yourself and ask? Okay, could I assume the hands were raised by mistake? Okay, I cannot hear anybody else asking questions. So I would like to end that.
Sorry, there's a comment there in the comment box, maybe from Jafet Olo, maybe you could raise the question.
About the recording?
No. A question to the presenters.
Oh, okay. Just sorry. I was
regarding the
looking at
spread of viruses. Maybe it's Jafet if it's there.
Jafet.
Okay.
Yeah, there's this question about how the viruses can be spread from rodents. And usually it occurs directly through bites when you get bitten by a rat or a mice, or it can be through indirect route, that could be through contamination of the food, fecal samples, or it could be through aerosolized means, when the fecal can be transmitted now through the hair. Thank you.
There's another question for you, Joseph, from Maria. She posted it in the chat. She was unable to unmute herself. And she asks, was the sample human population of people sick, or it was just persons who are at the community center without specific illness?
So the way we did the study, we were actually doing it at the hospital facility. So those who had reported there seeking medical health and they were having fever, so those are the ones that we did sample.
Okay, thank you for that response. So I don't see any other questions. And so we shall move to the next session. Thank you very much, Linda, and thank you very much, Joseph, for your very nice presentation. And thank you for participating in the conference. So I will go quickly to the next. We are still tackling infectious disease, and our next presenter here is Joseph Kuria, and they'll be talking about comorbidity with paracoccidioidiasis and blastomyces in TB patients in Kenya. Joseph, are you there?
Yes, I am.
Thank you very much. You
Can you see my screen?
Yes, your screen can be seen. Please put it on slideshow and proceed.
Okay. Thank you very much. Welcome to this presentation. My presentation is on comorbidity with paracoccidiosis and blastomyces in tuberculosis patients in Kenya. And those are the authors there and their affiliations. I have a brief introduction. TB, as you know, has emerged as a very important public health problem. And so accurate diagnosis is quite important for surveillance and treatment and control. It's particularly important because other agents other than mycobacteria can cause symptoms and lesions similar to TB. These are bacteria, other bacteria genera, parasites, and fungi. Among these other agents are the dimorphic fungi. We have 5 recognized dimorphic fungi. And they are referred to as dimorphic fungi because they can exist as either molds or yeast, depending on nutrition and the temperature. Well, one of them, blastomyces, dermatitis, and capsulatum, Histoplasma capsulatum. They have a worldwide distribution, but others like Nephei and paracoccidiosis and Coveted, they are said to be geographically restricted. Particularly the paracoccidiosis, is said to be restricted to South and Central America. And those people who get this disease outside Latin America, they are said to have traveled to those countries, or they have come in contact with people who have traveled to those places. When it comes to the blastomyces, the infection is mainly reported in humans and dogs in North America, but we have some isolated human cases in Africa, Israel, India, and Bangladesh. And in a previous investigation in this country, we identified paracoccidioides and blastomyces infections in cattle, and this raised the possibility of infection in other animals, including humans. And so this study aimed to determine and estimate the prevalence of the dimorphic fungi and TB co-infection in TB patients in Kenya. And we hope that the findings would strengthen diagnosis of tuberculosis, leading to effective management and control. We did this material, this work by collecting samples from 2 hospitals and 1 dispensary in Laikipia County, Kenya. These places, persons with TB are screened by examination of acid-fast smears, and patients found to be smear positive are put on medication. But also patients that have persistent symptoms and they are smear negative, they are also put on medication. After examination of sputum samples and recording of results, the samples are usually destroyed by incineration. And we collected samples that were designed for destruction by incineration. We selected Laikipia County because it's a rural setting, and the infection by dimorphic fungi takes place through inhalation of spores that are present in the soil. And so those persons that are involved in agriculture, that is crop production and livestock, they are most at risk. And we carried the laboratory analysis to the Department of Veterinary Pathology and Microbiology, University of Nairobi, and also at the Central Tuberculosis Reference Laboratory at the Ministry of Health. We collected samples between 2016 and 2017, and the samples were collected, labeled, and put in cooler boxes, transported to laboratory, and we stored these samples at -20 until processing. In the laboratory analysis, the sputum samples were processed using the sodium hydroxide enriched in sodium citrate method. And then we made smears from these samples, and we stained with the Nielsen staining method. And we examined for acid-fast bacilli and yeast fungi. Then we inoculated the samples into media for isolation of fungi, that is yeast extract peptone dextrose broth, which was enriched with defibrillated horse plasma. And it also contained antibiotics, chloramphenicol and gentamicin to suppress bacterial growth. And incubated these samples at 37 degrees for 2 weeks. We stained the cultures and examined for yeast fungi. To demonstrate dimorphism in the fungi, we selected some of the cultures and inoculated them into yeast extract spectrum dextrose agar containing plasma in strands, and we incubated 7 days. And then this was at room temperature. And then we introduced formalin into the cultures to inactivate the cultures, and we took samples and stained with phenocotton blue stain. And some of these modes that we are able to isolate, we wanted to demonstrate conversion back into yeast. And so we inoculated again into yeast extract spectrum dextrose containing host plasma. And we inoculated them at 37 degrees centigrade. And we got smears from these cultures and gram stained again. And the results we observed were as follows. In the sputum smears, we got acid bacilli in all the samples, meaning that the diagnosis in these centers was accurate. But in addition, in 37% of these samples, we were able to observe our yeast cells together with acid-fast bacilli. And the yeast cells were 3 morphological types. Type 1 were non-acid-fast cells, or partially acid-fast, or acid-fast blastospores with single buds formed on a wide base. You see the figures later, and these were observed in 9 of the samples, 9 out of the 7 samples. Type 2 are non-acid-fast cells bearing 2 buds or forming pseudomycelia, observed in the 5 smears of the 7 samples. Type 3, we had non-acid fast cells, either single or bearing a single bud from a narrow neck or in short chains, which you will see later in the figures, and we observed in 22 of these samples. And you can see there in the figure 1, you can see figure A and B. You can see cells having a single bud from a wide base. In A, you can see that they are non-acid fast. In B, you can see one that is partially acid fast. The others are acid fast. In the figure C, you can see cells bearing two buds. That is labeled number 3, and you can see the others. You have pseudomycelia. In figure D, you can see type 3 cells where you have either single cells or they have buds, single buds, or they have short chains. And the sputum culture, we obtained about 19 positive growths. In these growths, we had type 2 cells, and we also had type 3 cells. In type 1 cells, we never got any successful growth. There you can see in figure 2, you can see in A, there is a cell there having 2 buds. And in B, you can see pseudomycelia formed by these Brussels spores. And C, you can see yeast cells forming. B and C, you can see pseudomycelia. And in D, you can see this cell. There's a large cell with 2 buds there, and we refer to this as Mickey Mouse head. And you can see there the results also in A. You can see a cell there having multiple buds, where the buds resemble what we call a mariner's wheel, because there are many around the cell. In B and C, you can see we had colonies of yeast in the figure B. And in C and D, you can see a mixture of cells and hyphae. Those are basically what I have gone through in demonstration of biodimorphism. We got both type 2 and type 3 cultures and we also got the cultures of mold cultures, and with these cultures microscopically they were septic type with a very scarce and ovoid conidia at the tips. And when these molds were inoculated into the broth, they produced cells similar to what we have described. And like I have gone through the pictures, you saw the cultures of the yeast on the strands. In the discussion, here we can say that 9.2% of the patients we are able to find co-infections with dimorphic fungi, and we identified these as Paracocstoides and Brastomyces. The dimorphic fungi, each of them has a distinct morphology, either a yeast form or mold form or both. And in Paracocstoides, the yeast form has this characteristic large mother cell bearing narrow-necked multiple budding yeast, resembling the mariner's wheel, or a mother cell with 2 large buds resembling the Mickey Mouse head, which is quite characteristic of this fungus. The 2 morphological types of Paracocstoides were identified in this investigation. And we have 2 species in this genus, Brasiliensis and Rutzi, and now recognized. The Paracocstoides infections are considered restricted, like I said, to the desert rats in South and Central America. And those cases observed elsewhere are reported, are considered imported. And as I said, the identification of infection in cattle in Kenya previously indicated that infections by this fungus may be misdiagnosed. And we observed a prevalence of 7% in this investigation. In the endemic regions of South and Central America, about 15 to 20% of persons with tuberculosis are found to be infected with this fungus. When it comes to plastomyces infections, as I said earlier, they are reported mainly in dogs and humans in North America. In Africa, a few countries have reported these infections. And I previously said we have identified this fungus in slaughter cattle in Kenya. In this investigation, we got a prevalence of 2.3%. And we can say that dimorphic fungi infections have a serious implication in diagnosis of TB due to clinical and pathological similarities. We have noted that in Kenya, 60% of TB case notifications are composed of smear-negative cases. These have been reported by Kenya National TB Control Program. And we speculate that such cases may be inappropriately treated for tuberculosis and hence the need for specific diagnosis. In conclusions, we can say that we have identified the first human outside the presumed geographical restricted areas, and also the first plastomycosis in the country. And so routine TB diagnosis in the region should be considered these infections. A wider study is recommended to determine proportion of patients infected with dimorphic fungi, the correlation between infection and clinical disease, effect of co-infection on TB therapy, and the risk factors involved. And lastly, we could say that the opportunity favors a prepared mind, like Louis Pasteur used to say. We went out to look for zoonotic TB in cattle, and we came out with something unexpected. Thank you.
Thank you very much, Joseph, for your presentation and interesting findings on zoonotic TB. So I will go quickly to Edward Wasike Kitui. He'll be talking about postmortem microbiological isolates and susceptibility patterns among neonates who have died of neonatal sepsis. Edward, kindly take the stage.
Okay, thank you, Dr. Am I visible?
Yes, I can see your slides. Just put them on slideshow.
Okay. So as you've rightfully heard, I'm Dr. Wasike, and I'm going to take you through the postmortem microbiologic isolates and susceptibility patterns among neonatal sepsis mortalities in Kenyatta National Hospital. Other participants of this study were Dr. Waithera Lois, Dr. Walong, and I'm privileged to have Dr. Silvio Panga as my moderator, also as a participant of this study. And we had Dr. Marianne Moreithi. So neonatal sepsis is the third common cause of death in neonates worldwide. The first and second causes of neonates worldwide, mortalities in neonates worldwide, preterm births and intrapartum complications. Now, in this age of antibiotic resistance, we have a rapid rise, resistance in antibiotics worldwide, and this will further complicate the management of neonatal sepsis, and this is more so in the low and the middle-income countries, which have a higher burden of infectious diseases and restricted access to newer generation antibiotics. And of course, we have limited resources for supportive care and poor infection control measures. So routine surveillance of the etiological microorganism and their susceptibility patterns is very critical in detection of the changing trend of the antibiotic resistance. The complete diagnostic autopsy is the gold standard in ascertaining the cause of deaths. But studies have shown that minimally invasive so studies have shown that minimally invasive tissue sampling techniques can be used to obtain samples that can be used to determine the infectious causes of death. So the aim of the study was to identify the causative organisms, microorganisms in neonatal sepsis mortalities, and 2, to determine the susceptibility patterns of neonatal sepsis causative organisms, and 3, to determine the histopathological findings of the specified body organs among neonatal sepsis mortality. So this was a descriptive, minimally invasive tissue sampling cross-sectional study. And the study was carried out at Kenyatta National Hospital, Farewell Home in 2020, between the months of September to December. So we recruited 45 deceased neonates with a clinical diagnosis of neonatal sepsis. So after successful recruitment of the study participant, the bodies, having been refrigerated within 24 hours after death, were kept under 10 degrees Celsius. So the body areas that were to be punctured so as to obtain specimen for analysis were first cleaned with tap water and thereafter disinfected with alcohol and iodine. Now, fluid samples were the first to be collected. The fluid samples included the CSF and the blood. So on this pictogram, we can see a collection sampling of the CSF using a sterile 20-gauge spinal needle to obtain at least 6 milliliters of sterile CSF. Once the CSF was obtained, it was put in a sterile bottle, as we can see here, a Bajou bottle. And then we went ahead and collected blood. Mostly we did heart punctures using a 20-gauge IM needle to obtain at least 8 ml of blood. And then the blood was immediately put in a Btk culture bottle. So after collecting the fluid samples, we went ahead and collected the tissue samples. The tissue biopsies included the brain, the lung, and the liver. So on this pictogram, the one that I'm showing is a procedure where we're trying to get the brain tissue through the nuchal area using this biopsy, the core biopsy gun. And here, over here, is an attempt to obtain lung tissue through the axillary area. So once tissues were obtained, the tissues, we first obtained those for microbiology. They were put in the sterile bottles. And then those for histology analysis were put in the tissue cassettes, which were then fixed in formalin. So the samples were then taken to the Kenyatta National Hospital, microbiological and histopathological labs for further processing. So out of the 45 deceased neonates with a clinical diagnosis of neonatal sepsis, the age ranged from 1 to 27 days, a median of 8 days, and a mean of 9.8 days. And those neonates that were aged 1 day, we only found 1, and the neonates between 2 to 3 days were 6. Majority of the neonates were more than 4 days. And we had 24 males and 23 females. And we had 53% had a normal birth weight, and 46% had a low birth weight. And out of the cases, we had 49% preterms, and 51% were term neonates. Most of the deliveries were via the spontaneous vertex delivery, 64%. Others were through CS. And most of the neonates were referrals from other facilities a percentage of about 60%. So the culture yields, out of the 45 cases, there was an aggregate of 224 samples obtained, and that is 5 samples from each case, that is from the CSF, the blood, brain, lung, and liver. And there was one CSF dried up. That's why we had 224. So there were 54.4% positive yields. We were able to isolate. In 54%, and we had in 40% we had no isolates, and we had about 5% contaminants. And as we can see in the CSF, we didn't have any contaminant. So the prevalence, we had gram-negative were prevalent isolates, and then followed on by the gram-positive bacteria. And this is the prevalence of the microbiological isolates. The most predominant organism that was isolated was Kleb pneumonia, and then followed up on by Enterococcus faecium, and so forth, as we can see here. So the microbiological isolate distribution by each specimen, as we can see, Kleb pneumonia, the predominant organism isolated. We had more isolates from the blood, and then other isolates from the liver and the lung, and so forth. And this is how the trend was. So prevalence of the gram-negative Kleb pneumonia, of course, the predominant organism, and then followed on by the Enterobacter cloacae, Escherichia coli, and so forth. And then we had prevalence of the gram-positive. The most organism isolated was Enterococcus faecium, then followed on by Enterococcus faecalis. So for all the cases, I wanted to see how, if I would be able to isolate only one organism, or I'll be able to isolate many organisms. So in 6 cases, we were not able to isolate any organism. And in 30 cases, we were able to isolate singularly one organism, that is monomicrobial isolates. And in these 30 cases, 21 cases were due to Klebsiella pneumonia. And in 7 cases, we had 2 different organisms. And in 2 cases, we had 3 different organisms. And this is serialized cases to show the polymicrobial isolates. For instance, in a case, we had a combination of Staph hominis and Staph hemolyticus. Another case, we had a combination of Enterococcus gallinareum and Acinetobacter baumannii, and this is how they went. An example of a case that we isolated 3 organisms. We had coagulase negative Staph, and S1eri and Klebsiella pneumonia. So comparison of the antemortem data and postmortem isolates, we were able to find records for 14 cases. And in those 14 cases, this was how the isolates were found. And most of the isolates were Kleb pneumonia. And in postmortem, we were also able to isolate Kleb pneumonia predominantly. So there was a close correlation of the antemortem isolates and the postmortem isolates. So over to the resistance pattern, the gram-negative bacterial resistance pattern. We only looked at 3 first commonest, the gram-negative organisms. And we see, for instance, here, Kleb pneumonia, that it had a high level resistance against the first line antibiotics that are recommended by the WHO. And there was good response to amikacin and meropenem and ciprofloxacin. And this was more or less the same pattern when compared to the other gram-negative bacteria. And amongst the gram-positive bacteria, looking at Enterococcus faecium, there was high-level resistance against the first line and even the second line antibiotics that are recommended by the WHO, and good response against the linezolid, teicoplanin, and tigecycline. So histopathological findings were generally non-specific, and you could not come up with a diagnosis of neonatal sepsis by looking at the histopathological findings alone. And therefore correlation of the clinical picture and other investigation is very important so as to arrive at a diagnosis of an infectious cause in using the histopathology. So in conclusion, we found that the most prevalent isolates were the gram-negative bacteria, and overall, Kleb pneumonia was predominant. Multi-drug resistance was high, and extended spectrum beta-lactamases were prevalent in magnitudes observed in hospital-acquired infection outbreaks. And histopathological findings appear mainly non-specific, and these minimally invasive tissue sampling techniques can be used to aid in bacterial surveillance that will inform the Antibiotic Stewardship Committee. Thank you very much. I would like to acknowledge the KNH Farewell home staff, the KNH microbiological and histopathological labs for the support accorded to enable successful completion of this study, and the ICH 2021 team giving us this platform to share our work. Thank you. Over to you, Dr.
Thank you very much, Edward, for your interesting presentation. It just brings a new angle to how stewardship is done on antimicrobial use in such a way that you can actually apply post-mortem data in, and it can actually even show you the trends in resistance. So I would like to go to the next presenter. The next and the last presenter is Victor Moses Musyoki, and he's going to talk about speciation and antifungal susceptibility of Candida isolates from diabetic foot ulcer patients at Kenyatta National Hospital. Please go ahead, Victor.
Thank you so much, Dr. Ari, for the opportunity. My name is Victor Moses Musyoki. I'm a PhD student in the Department of Medical Microbiology, University of Nairobi. This was part of my work that we did initially, and it's on speciation and antifungal susceptibility of Candida isolates from diabetic foot ulcer patients in Kenyatta National Hospital. Part of the research work and supervision was done by Professor C.F.O. Otieno, Ms. Winnie Mutai from UoN, Dr. Nancy Ngugi from KNH, and Dr. Moses Masika from University of Nairobi. So diabetes is a metabolic non-communicable disorder that has been associated or affects insulin production and activity. And according to International Diabetes Federation in 2019, 463 million people globally are living with diabetes. This translates to a prevalence of 9.3%. The IDF projects 700 million cases by 2045 and 143% increase in Africa. This is according to modeling studies that have been done, showing that cases of diabetes are on increase. This may be associated with sedentary lifestyle and also unhealthy dietary intake. Diabetic foot ulcer is one of the most common complications and is associated with premature death. This affects approximately 60 million diabetic patients globally. The DFU creates a portal of entry for contaminating and infecting microorganisms. The damaged blood vessels which line these cells cannot regulate glucose influx. This initiates damage to the tissue organs, and also the influx of glucose into tissues supports the growth of microorganisms. This is bacteria, viruses, fungi, and also imported some of the microorganisms like the cardiovirals in the virology order. The DFU is associated with extended length of hospitalization and also non-traumatic amputations. So what was the problem statement in this study? There is increased morbidity, mortality, and management cost of DFU, and especially those which are microbial infected. There is also a challenge in clinical management of fungal infections, considering that there is compromise, there is a emergency of antifungal drug resistance, which we've seen to be or remain a global public health concern. Then there is lack of data, mycological data, especially in Candida species, and also antimicrobial susceptibility profile. The only organism that has been highly isolated in other anatomical areas has been Candida albicans, and this study was able to show, or was intending to show, the significance of non-Candida albicans species in diabetic foot infection. So the justification is Candida being one of the organisms or yeast in the fungi kingdom. It is part of the microbiome, and more specifically microbiome in the diabetic foot ulcer. So this will address the knowledge gap that only bacteria exist in this DFU. The other important area that we to justify this study was to track antimicrobial resistant trend in Candida that is infecting the diabetes foot ulcer, and also for relation and review of treatment policies and guidelines in management of DFU. The study objective, the broad objective, was to determine the prevalence and antifungal susceptibility of Candida species isolated from diabetic foot ulcer patients in Kenyatta National Hospital. This was a prospective cross-sectional study conducted at Kenyatta National Hospital. We recruited diabetic adult patients presenting with active foot ulcer between June and September 2019. Our sample size based on the Cochrane formula calculation was 123. So for the laboratory procedures, social-demographic and clinical data from the 152 patients that were recruited for this study was collected using structured questionnaire, and samples were collected using a sterile swab, where we performed the KOH, that is potassium hydroxide microscopy technique. This was to visualize the fungi that could be present in these tissues. Then we also did inoculation of the specimen onto subread dextrose agar. This SDA medium has been supplemented with chlorophenicol and gentamicin to inhibit the growth of bacteria. Upon incubation at 37 degrees for 18 to 24 hours, we performed germ tube test to identify and differentiate Candida albicans and Candida dubliniensis. And from the pictorial, we can be able to see a true hyphae forming from the Candida organism. And on the upper side here, we're able to see, this is a gram stain showing the yeast cells, which are gram-positive cells. The identified using the Vitex system in Kenyatta National Hospital Microbiology Lab, and the Vitex system also performs AST. Further identification of the yeast cells was done using the MALDI-TOF. This is matrix-assisted laser desorption ionization time of flight. This is a technique that in less than 20 minutes we're able to identify the microorganism. So once we identified the microorganism, we were able to perform antifungal susceptibility testing using the Vitex. The identification and AST data was retrieved from the Vitex system and imported through a backlink to the WUNET software system. The WUNET software system is a CDC coordinated software that is able to guide microbiologists in analyzing data for antimicrobial susceptibility. The data was finally analyzed using IBM SPSS version 21. And our results were, out of the 152 participants, 77 were from the diabetic outpatient clinic, 47 from the medical ward, 12 from the orthopedic ward, and 16 from surgical outpatient ward. Majority of the study participants were male in our study, and 31% were between the age of 40 and 50, 80% were married, and more than 54% had post-secondary education. In terms of clinical characteristics, 98% of the study participants had diabetes type 2, and more than 29% had lived with diabetes for the past 15 years, and only 21% had lived with diabetes for less than 5 years. In terms of duration of the DFU in months, 80% had diabetic foot ulcers for less than 3 months, with a mean of 2.58 and a median of 2, with an interquartile range of 1 to 3. In terms of Wagner stage classification of the DFU, 61% had grade 2 DFU, with 58% experiencing the second episode of the DFU. For the fungal isolation, out of the 152 samples collected from the recruited study participants, 39 showed fungal growth, where 31 had yeast. This is Candida species, and 8 had molds. Out of these 8, we were able to isolate on this SDA media, Trichophyton species, Microsporum species, Aspergillus species, and Penicillium species. On Candida, we performed gram stain, where there were gram-positive cells. On molds, we were able to perform lactophenol cotton blue presentation upon isolation on the medium. So on the molds, the different characteristics, for example, in the Trichophyton, in this micrograph, we are able to see that the colonies are flat with a dark brown pigment production at the reverse side. Then on lactophenol cotton blue, there is spiral hyphae that aided in identification. On the second one, we see this is Microsporum canis, and there is presence of macroconidia that is spindle-shaped. For the Penicillium and Aspergillus that was isolated from the SDA medium and from the samples, see lactophenol cotton blue was used for identification microscopically, and we see the brush-like presentation of the hyphae and the conidia. This is Aspergillus on my right side of the screen. This is Aspergillus growing on SDA medium, and the conidiophore with a bulging vesicle and connected to the conidia. In terms of distribution of fungi, 75% of the samples or the isolates were Candida albicans, and the non-Candida albicans species included Candida lusitiniae, Candida dubliniensis, Candida parapsilopsis, glabrata, tropicalis, and formata. Candida infection, based on demographics and clinical characteristics, we did an association to determine whether these social demographic and clinical characteristics were associated with Candida infection. And this shows there was no significant association between the patient characteristics and Candida infection. Isolation of microorganisms from the wounds were also considered, looking at monomicrobial isolation versus polymicrobial infection. And 80% of the samples had mixed infection, signifying that the DFU is polymicrobial in nature. And out of these, 20 had pure culture of Candida species, among which 13% were Candida albicans. For the antifungal susceptibility profile of Candida species isolated from diabetic foot ulcer patients in KNH, this was determined using the Vitex system. In our results, we see the non-albicans Candida was highly sensitive to most of the antifungal agents that are commonly used. This includes amphotericin B, the caspofungin, flucytosine, fluconazole, micafungin, and voriconazole. For Candida albicans, where we tested 27 isolates, 74% in voriconazole, micafungin, fluconazole, and caspofungin showed susceptibility, and only 81% of these isolates were sensitive to amphotericin B. So in conclusion, Candida albicans and non-Candida albicans species are part of the polymicrobial nature of BFU. Candida albicans is the most predominant species, and this showed low resistance rates to the commonly administered antifungals. And therefore, species identification and AST is vital in determining the appropriate therapeutic agent for treatment of BFU infected wounds. So our recommendation was we propose addition of fungal diagnosis to routine bacteriological assays of specimen from BFU patients. And we also recommend that future research should look at the diabetic foot ulcer microbiome to be able to understand, apart from bacteria and fungi, what else is present in these wounds. And is it all microorganisms present in these wounds pathogenic? Because the use of antimicrobial agents in these patients increases chances of antimicrobial resistance. Then we also proposed that the future research to look at the role of biofilms in disease progression. From literature, it has shown that Candida albicans is the initial organism that initiates biofilm formation, recruiting Staphylococcus aureus through the AGR process in quarantine sensing. And also to look at the immunology of DFU, because we understand that DFU, in terms of wound healing, they usually have inflammation phase, and therefore the damage is cytokine mediated and microbial damage. Last recommendation is that we propose or recommend strengthening the fungal susceptibility surveillance of clinical isolates and antimicrobial stewardship programs. I'd like to acknowledge the supervisor.
Victor, are you still there? We seem to be losing you. Victor?
Yes, I can hear you. It seems I dropped. Can you hear me?
Yes, I can hear you right now.
Sorry for that. For the acknowledgement, we'd like to acknowledge the Department of Medicine, KNH, Department of Laboratory Medicine, also KNH, the KNH-UoN and Department of Medical Microbiology for coordinating this work, and also KNH Research and Programs for funding the study and not forgetting the patients in KNH facility. Thank you.
Thank you very much, Victor, for your presentation, and being the last one to present again, thank you for your patience. Now on to the question and answer session. Please, participants, keep them coming. Dorothy Chemutai, I can see you raised your hand. We are unable to unmute you, so please just type your question and we shall ask it. So while Chemutai is typing her question, I would like to start with pose a question to Edward, and my question would be, when you're looking at the patients who had polymicrobial infections, did you ascertain whether these were patients coming from the community, other facilities, or in Kenyatta? Edward?
Yes, Daktari, I'm here. So I didn't dig into the clinical information to find out whether there were referrals. So I'll not be quite precise to answer that. But by and large, as the study has shown, that most of the cases were referrals. Yeah. So.
Okay. Thank you. Your second question is, how are you going to use these findings to impact antimicrobial stewardship programs that are currently ongoing in Kenyatta, and how do you see yourselves in pathology partnering with the antimicrobial stewardship team? Because your results really raised something important, especially when you looked at the resistance patterns of most of the first-line medication.
So postmortems as a tool to ascertain the cause of death, and to enable us to improve the way we manage our patients. More or less the same if we go ahead and not only stop at the clinical, isolating these organisms at the lab when these patients are alive, we can go ahead and follow up even at post-mortem to see whether we can still isolate the same organisms or there are other organisms that we are not able to isolate. And especially now that at post-mortem, we're able to do more, look at the tissues. Yes, so it's a good, it's a good add-on to go on more than the clinical investigation. So yeah, I look at it like not only stopping at during life, but looking at
Yes, thank you, Edward. One question to Victor. When you were sampling your patients, did you go ahead to look at their immune status as well? Because that can actually affect whether a patient is having mono, polymicrobial, severe disease, and even the grading.
Thank you so much for the question. When we were recruiting the patients, we managed to exclude patients who are on any immunosuppressive therapy or steroids, and also immunosuppressive condition like the HIV patients. We did not look at the immunological assays per se, but that is one of the recommendations that we really brought out clearly, that we need to look at the immunology of the DFU in relation to microbial infection. But from literature, we understand that the DFU stall at the inflammatory phase of wound healing. And this is because of continuous interaction of the immune system with microorganisms, and especially pathogenic microorganisms that have been able to develop the biofilm.
Thank you very much for that. That's a good answer. Someone is asking if you could kindly share your slide, Victor.
Sure. Yeah, we can share the slides with, there is no problem.
Okay, thank you. And Victor, just one last quick question.
Yes.
Your study has shown a slight increase in, we are seeing an emergence in antifungal resistance, which you recommended that we need to do a lot more of antifungal stewardship with antimicrobial stewardship. There are ongoing antimicrobial stewardship. How do you propose this can be done?
From surveys that have been done from laboratory end, it shows that majority of the samples that come from DFU patients only request for bacteriological cultures. And therefore, one of the recommendations is to include antifungal testing into bacteriological assays. In terms of antimicrobial susceptibility and integrating this, if I got your question clearly, is during the stewardship committee, the focus should not only be antibiotics, but also to consider antifungals, because this is an area, mycology is an area that is not well understood, and it's an area that is not highly explored when it comes to medical and clinical for management of patients. And the narrow scope or limited classes of antifungal can really increase chances of AMR. And therefore, incorporating antifungal during stewardship committee, that can really help with continuous surveillance of these resistant isolates. Although our study has been able to show that low resistant rates have been identified, and maybe to just mention, this is one of the, to the best of my knowledge, this is the only study that has been done in Kenya for fungi on DFU. So we highly propose that the Antimicrobial Stewardship Committee to consider antifungals.
Thank you very much for that study. This is adding to the body of knowledge, and definitely this will also serve as a study in other areas to look at fungal infections in diabetic foot ulcers. James Maura had raised his hand, but I propose that James kindly just type your question on your Q&A, because we are unable to unmute you from this end. Just type your question and we'll be able to address it. While we are waiting, the next session will be the poster session, and they will start from now up to 6 p.m. So just feel free once again to review the posters. And if you're a presenter with a poster, kindly log in so that you can be able to respond to questions that are regarding your poster. James, Maura, I'm still waiting for your question on Q&A. I can still get that question. Let me just check the chat. Maybe it could be there. Can't see anything on chat either. So that will mark the end of day one. I'd like to thank everyone for staying and for being very patient on this first day. Thank you so much to all the presenters for your very insightful presentations, and the participants, because without you really, we wouldn't have a conference. We start again tomorrow at the same time, so please avail yourself, because we'll, okay, people are raising hands. Kindly just type any question or comment that you might have, because I'm not able to unmute you to speak. Wairimu Mbutia, kindly. Maura, I'm also waiting for your question or comment. Okay, I don't see anything on the question and answer or the chat section. So probably it was a mistake. So as I was saying earlier, yeah, Warimu says that was a mistake. And thank you so much to everybody who participated. We expect you tomorrow. Thank you for making day one a huge success. And thank you, everyone. I'd like to wish you a nice evening as we proceed to the poster session. Thank you very much.